Good afternoon. Welcome to the Senate Finance Committee. Today is Wednesday, March 4th. We are going to hear 14 bills. I'm going to ask that the sponsors can take as much time as they need to present a bill, but the witnesses get 2 minutes. Please be respectful because we have, I think, 94 witnesses today. So be respectful to the people that are coming behind you. You'll have a buzzer that'll go off and a light blink, so please pay attention. Senator Feldman, I'm sorry for keeping you waiting. I didn't have enough time to get anything to drink or go to the bathroom.
It's all good, Madam Chair. We're all in the same boat here. Okay, thank you, Madam Chair. Good to be back here for the second straight day. And so I was here yesterday talking. Oh, can I bring my two witnesses? I've two. Is it just one or two?
He's right there.
Okay, one virtual, and then Caitlin here at the table. So I was here yesterday with a bill that I mentioned about this issue here in the state of all these reports talking about our stagnant economy, not enough private sector job growth, anti-business branding problem. And this body, I'll reiterate what I said yesterday, need to look for ways to address the problem. And I believe Senate Bill 779, like the bill I presented yesterday, is a step in the right direction. You'll see support from the Maryland Chamber and several other business groups. So by way of background, back in 2021, the General Assembly established a 24-person work group tasked with creating policies to help out with some of these issues that I just described. And it concluded with a report in December 2022. One of the members of that work group was none other than your own Senator Johnny Moutz. And Madam Chair, if I might just refer to that as the Moutz Work Group for purpose of this bill 779, which, by the way, the Senate Bill 779 is entitled the Better Small Business Employee Benefit Act of 2026. And that work group issued a report December 2022. Just also, I think it's important to note that 96% of Maryland businesses have 50 employees or fewer, small businesses. That's a large chunk of our state is in that category. So that work group, the Moutz work group, came up with 9 recommendations. And recommendation number 4 was to pass legislation that would open up and allow businesses with 50 employees or fewer, small businesses, greater access to professional employer organizations, also known as PEOs. And what is a PEO? Generally, a professional employer organization, PEO, allows small and mid-sized businesses to outsource various administrative functions such as payroll, retirement, training, tax administration, regulatory compliance assistance. And they can also offer health insurance through the PEO's large group health plans. This helps small businesses streamline their operation, reduce administrative burdens, and ultimately, Madam Chair, save money. Nationally, there are over 500 PEOs, again, across the country, providing services to 208,000 small businesses. Here in Maryland, if you look at the fiscal note, we have 73 PEOs, again, according to the fiscal note, operating in the state of Maryland. Now, a Maryland employer right now can use a PEO for HR, payroll services, pension, and retirement plans, but they cannot access PEO's large group health plans. I just want to make the point, PEOs are not insurers, they're just group purchasers. So Maryland is one of only 3 states in the entire nation, Maine and Wyoming being the other 2 states, that prevent PEOs from offering large group insurance plans to its small businesses, even if it can result at times in massive savings in healthcare costs for those businesses. Again, 47 states allow it. Maryland, Maine, and Wyoming are the outliers in the United States. I'd also note the businesses that use the PEOs have growth rates more than 2 times higher than non-users, an employee turnover rate that is 12% lower, and are 50% less likely to go out of business. PEOs help small businesses, allowing them to have the privileges of large businesses when it comes to administrative functions, as I mentioned, but in Maryland, not when it comes to health insurance. And again, one of only 3 states in the nation with such a prohibition. And this particular issue, I think, is more pressing now than ever because small group exchange plans are increasingly under risk due to changes in federal support and protections at the federal level. So fundamentally, 779 merely aligns us with 47 other states. It puts in statute a definition of a PEO, allows PEOs to offer large group health insurance plans to their small business clients, allowing them to access larger and more comprehensive health insurance plans, does not mandate participation, just provides more options, flexibility for small business when it comes to offering their employees health insurance. Now, what happened, that's those recommendations that I mentioned earlier from the prior Mouts work group report, number 4 in particular, was not really studied. There wasn't a lot of data surrounding the recommendations. So I came to this committee in 2024 with Senate Bill 821, which came to the committee, passed unanimously, which required the Maryland Insurance Administration to study PEOs in the state, review regulations in other states, address any potential impacts of proposed statutory changes in Maryland relating to the offering of health coverage by PEOs, the implications on the small group market, which has been a primary concern over time by the MIA, with, again, going this route. And then that study resulted in a study report in January of 2025, Madam Chair, and I have this report here. I've submitted it with my testimony, and at your leisure, you can read it. And so that's kind of where it's at now. What I would say, 2 things. I'll just get right to the 2 issues, the 2 letters that have come in, letters of concern from the MIA and Health Benefit Exchange on this piece of legislation, again, that would align us with 47 other states. And first, and this has come up before, having to do with concerns about the impact of this bill on the small group market. Okay, and that small group market, I will say at the outset, has been an important tool for businesses and organizations to offer health insurance to their employees. And the Maryland General Assembly has worked very hard, a lot of that being here in the Finance Committee, to keep this option strong and viable. Basically, the results of this study in January 2025 were inconclusive as to how that group market would be affected by what's seeking to be done by this bill. Specifically on page 2 of this report from January 2025, you'll see that it says research performed in the course of the study found a lack of any empirical data available to conclude that PEOs would have any negative impact on our small group market. That was the report. Now let's transition to today. I just got this fiscal note 10 minutes ago, and if you look at the fiscal note on page 3, I'm going to read it. Again, citing to that same report, the MIA found limited data to demonstrate any direct causation between allowing small businesses to purchase large group health insurance through PEOs and any deleterious effect on the small group market. So that is what the fiscal note references. That's what the report found. And then on top of that, well, actually, let me read just one other sentence from the fiscal note. It talks about small business effect. Certain small employers will be able to obtain a large group health insurance coverage through a PO, which may be obtained at lower premium rates. However, premium rates for small employers who are unable to join POs and instead remain in the small group market may increase. So it would have, again, according to the fiscal note, potentially increased costs on a lot of our small businesses in this state. So again, back to this report from January 2025, the Maryland Chamber of Commerce notes that prohibiting PEOs from offering aggregated health plans to their small business clients puts Maryland businesses at a competitive disadvantage compared to other states. PEOs in other states have shown that they can exist alongside robust markets without adversely impacting the broader market. That's on page 21 of the January 2025 report. Also on page 25 of the report talks about a similar report concluding there's no evidence that off-market product offerings, specifically including PEO-sponsored plans have any material effect on the small group market's composition or stability. DC and Virginia allow PEO-sponsored plans. They've coexisted alongside small group markets for a long, long time, for decades. Again, that's all in that report. Market dynamics have the effect of PEOs in terms of them being compliant with a lot of the protections that we always talk about because the market dictates they would do that. And then a couple of final points, Madam Chair. The MIA raises an issue about disclosure requirements in the bill, and they assert that because they're unenforceable, because MIA does not regulate PEOs. And the disclosure language, first of all, is about transparency. We're putting that in statute, saying that if you're going to sell, you're going to have to do disclosures. And again, these are typical disclosures in place in the regular course of business all over the rest of the United States. But the fact that the MIA does not directly regulate the PEOs, it doesn't really make a lot of sense, because if you think about it, there's a statutory disclosure that I think any PEO wanting to participate here would abide by. Also, it's almost always under detailed written client service agreements. There's a contractual arrangement. If you're going to have these disclosures in statute, it's going to almost certainly make its way into these client service agreements. And so if you don't do that and you don't provide those provisions and those disclosures, everything you say that you're going to do, you don't do, you're going to be in breach of contract with whoever you're doing the. So the issue of enforcement, I think, is not anywhere near, or I would say even arguably, a red herring. So, Madam Chair, in sum, notwithstanding, I would say these letters of concern, vague letters of concern, both in the report, the fiscal note, there's no evidence to support the notion that the small group market would be undermined by simply allowing small business owners the opportunity to offer health insurance through another avenue, a PEO. And again, 779 merely aligns us with 47 other states, allows PEOs to offer large group health insurance plans to their small business clients, allowing them to access larger and more comprehensive health insurance plans. And finally, as I said at the outset, we need to start passing bills that reverse course on our anti-business branding problem, and I think this legislation is a step in the right direction. And so with that, Madam Chair, I can take questions, or you can take the two witnesses, and I will stay here and take questions after that.
Senator, typically we finish your panel and then we have questions.
Yes,
So
that
Kate,
works.
would you like to go
Do the
next?
same way. That's perfect.
Thank you, Madam Chair, and thank you, Chair Feldman. Good afternoon, Madam Chair and members of the committee. Caitlin McDonough on behalf of the National Association of Professional Employer Organizations, or PEOs, on behalf of our small and mid-sized businesses and our worksite employees that we represent here in Maryland, here in support of Senate Bill 779. I know this is an issue that's been before the committee before in prior years, but with affordability and economic development being top priorities for this committee and for the General Assembly this session, the continued increased cost of health care and the lack of stability at the federal level, combined with ever-growing complexity and cost issues for small businesses in Maryland, we urge the committee to consider this common sense legislation that gives more options to small employers and makes them more competitive with both with other states and with their large counterparts, all at no cost to the state. Despite the fact that small employers employ nearly half of the workers in Maryland, only about 34 to 35% of them provide employer-based health coverage. And those numbers are even lower for minority and women and immigrant-owned businesses. These businesses repeatedly cite affordability and lack of options as the primary reason for not providing coverage. Senate Bill 779 addresses both of those concerns by giving small employers at least one more option and one more pathway to determine what's the right plan and the most affordable plan for them and their employees. These are high quality, competitively bid national plans in the large group market. And Eric Foster, who's going to join us virtually, can provide more details about what these plans look like, what the benefits entail, and how robust they are. So I encourage questions to him. As Senator Feldman mentioned, 48 other states, or 47 and DC, allow this, and he also very robustly addressed the small group market issues, but happy to answer questions about that. But ultimately, this is a bill about economic development. It's about giving options to our small employers. It's something our clients are asking for all the time. We have seen it in 48 other states, and we just want to be able to provide these options to our employers. So with that, I urge a favorable report and happy to answer any questions or discuss any of the opposition.
Thank you, Caitlin. Now we'll hear from Eric Foster.
Good afternoon, everyone. Good afternoon, Madam Chair and members of the committee. I'm Eric Foster. I've been working with PEOs for the past 30 years. Our business is an actuarial and underwriting firm specializing in pricing and following the performance of small businesses in PEO master health plans. To provide some perspective, we quote 20,000 small businesses a year into policies sponsored by 40 PEOs across the United States. And we currently underwrite in partnership with 18 different insurance carriers, including Aetna, United, Cigna, and numerous Blues organizations across the country. Our approach to this is not to replace any market, but to simply provide additional options to small businesses that are cost effective, help them stay in business. And as the senator said earlier, there's a requirement that businesses have a contractual relationship with a PEO for multiple services. So they're entering into a client service agreement that is a precursor to being able to access the plans. There's a stickiness there as well that comes from that. In our experience, all of the plans that are offered by the carriers playing in the space offer plans that meet metal value. So they are equivalent to metal values offered in the ACA. They meet minimum value. They pass mental health parity testing, and they pass Medicare Part D credible coverage testing on pharmacy benefits as well. 1 in 6 groups that we quote into these benefits don't currently sponsor health plans at all. So we're providing an avenue to small businesses accessing benefits that they don't currently have in existing markets. It's not just about the healthcare rates either. We quote and we retain business across a wide spectrum of rates. About 30% of the groups that we renew into rate sets that are higher than what they would pay in the ACA marketplace. So it's not about simply selecting certain groups. Also, more than 90% of carrier dollars go to pay for benefits.
Thank you. I don't see any other questions, but I do have a question. There's a number of letters of concern, as the senator and I talked about, but this is the one that's of greatest concern to me. This is from the MIA. For employers who join a PEO headquartered in a different state, the bill would allow Maryland consumers to access those large group benefits and rates without any of the protections afforded by Maryland's current law, including Maryland's mandated benefits, which are 50, by the way. Additionally, the MIA's ability to assist these consumers with complaints regarding their coverage will be limited due to lack of jurisdiction. For employers seeking to join a PEO located in Maryland, this bill will allow PEOs to operate outside the regulatory framework of Maryland's small group laws. This means that the policies insured by in-state PEOs may not provide all the protections mandated under Maryland's small group law and may also underwrite based on health status and other factors. So who would like to respond?
I'm happy to, Madam Chair, if that's all right. So, I mean, and that is absolutely true. I mean, these would not be MIA-regulated plans. And as we often hear, as one of the lobbyists who's often in here lobbying for mandated coverage under MIA-regulated plans, we know that that only affects about 18% of the insureds in Maryland. So these plans are, and as Eric mentioned, are going to be these robust large group plans that are highly competitive and across all the different carriers, either regulated federally, depending on their, if they're self-insured or not, or self-funded or not, or if they're based in another state. That's the vast majority of the plans in Maryland. These are your union plans. These are your county plans. I mean, they're regulated in all the same ways that, so I mean, we do believe these are robust benefits. We think they're going to give options and affordability, and they would be regulated in the same way as the vast majority of the plans in the state. So it should not be unfamiliar to the committee or to the administration.
Senator Mounts.
Can I just one other, I mean to harp on this, but I would be interested since, I keep talking about just aligning with what 47 other states. We are one of 3 states in the United States of America in this, I would say, rather odd situation. I mean, I don't know of the MIA equivalents in the other 47 states, where this, including DC and Virginia, where I assume, the same kinds of issues would arise regarding regulatory oversight, and yet I have not heard. There's been no testimony. MIA and the Health Benefit Exchange are not here to testify, so we can't actually press them on any questions, or you all can't. But, I think Caitlin probably was responsive to that. But ultimately, there's no evidence in either the report or from any other state that is a problem anywhere else in the nation. So I just put that out there.
Senator, other states don't have 50 mandated benefits. That's part of what makes us different, but
Yeah.
Senator Mouse?
Thank you, Madam Chair. I think my mic was cut because they just called me to run to JPR, but this issue is so important for so many of my constituents. I want to stay here just to get this question on the record and thank the chairman for our hard work on our task force and our great 9 recommendations. And to name it the Johnny Mouse Task Force is a huge honor, so thank you. But and an
I
overstatement.
should have said, Pam Bottle, what work group, even if you were on it or something like that.
I once had a principal, and he used to say to us in the morning, "Good morning, gentlemen." We use that term "gentlemen" loosely. But another issue that's come up in the testimony, I'd really like to give you the opportunity to address is that, I hear about this all the time. All the time. It's been going on for over a decade from local small businesses that want to be able to join large pools. And one of the arguments is that, well, if we were to do this, then the healthy people would leave the small individual market and then they would go to these pools and thereby, deflating the small market, almost like, this doomsday scenario, this massive crash. I know you've already mentioned this is operating in 47 other states. The concept that this would somehow crash healthcare, could you address that?
Well, I'll let Kate, but I'll just go right to the fiscal note and this report from January 2025, which says the MIA found limited data to demonstrate any direct causation between allowing small businesses to purchase large group health insurance through PEOs and any deleterious effect on the small group market. So this report from the MIA specifically does not, and I'm looking at page 2 of the report, the fiscal note, there does not seem to be any evidence to support any causation between those two things. And so I'll just defer to, again, the fiscal note and the actual report that studied that we came in, this committee passed a piece of legislation in 2024 that asked the MIA to look at that very issue. And they looked at it and they concluded that there's no causal connection or no problem. So anyway, that's all I have to say.
And just for clarity on the way a PEO would work, and Eric alluded to this too, so we contract with the small employers. They're making a pretty big decision to enter into this co-employer relationship with the PEO, and healthcare will be one of those factors. You're not going to do this just for healthcare. You're going to be getting your workers' comp, your 401k, your tax compliance, everything. Family leave is a big one. So we take the employer and then all their employees. We can't go through their employees and only take healthy ones or things like that. So this idea of cherry picking at the individual employee level is just not how it works. And I think what we are more likely to see is if you do have an employer, a small employer that has a young, relatively healthy employee base, they may opt not to get insurance at all and pay their employees more, give them a stipend, or just not do it at all. And that's what we're seeing more than accessing health and coverage through a PEO plan like this. We'd like to see more people getting insured through this option, through any other option that's available to small employers.
And also, this is not mandatory. This is optional. So if you want to go to something that's got a lot more stuff, there's nothing in the bill that precludes you from shopping around.
Thank you.
Better go to JPR. Senator Reedy?
Thank you, sir.
Very quickly, thank you, Madam Chair. Every year, my first job working in politics was as a college student. I interned for a small business organization in D.C. that was opposed to buying insurance across state lines. It was really interesting. And I feel like if this argument is used a lot about, well, if it goes across state lines, we don't get the different mandates, we don't get the we've got small businesses drowning. It's like they need some options. And people can always, correct me if I'm wrong, can people go purchase insurance on top of the insurance that they have through their company if they wanted to?
I mean, anyone has access to the individual market or to go, I mean, I opt out of my firm's insurance because I'm on the state employee health plan.
Right.
And our firm does pay about $70,000 as a 9-person firm on the exchange right now. So
It's a
I
lot.
prefer my large group plan.
I guess I would, maybe Eric is the person to ask this question to. Talk about the suite of services that one of these provides on the health insurance system. So they're not going to comply with all the state mandates.
Mm-hmm.
But that, I imagine you're also not sending your clients to a big concrete building in the middle of nowhere. So I mean, what are we?
Eric, would you be able
Yeah.
to give a
Is he
little more
able to
detail
comment
on the
on what they
plans?
do?
Yeah.
Yeah, sure. So PEOs compete by offering what they term as Fortune 500 level benefits. So imagine the same access to care, the same access to the qualified contracted providers that you would find in ACA markets where carriers play. Many carriers choose not to play in the ACA market in certain states, but the same networks, the same providers, the same level of benefits are provided through their large group plans. PEOs don't take shortcuts in what they offer. They offer a variety of price points, obviously. So they might have things that are qualified plans that can partner with an HRA. It may be an HDHP style plan design, or it might be a rich plan design with low cost sharing features. There is nothing that is draconian or prevents access to care in the benefits that are offered. It's the same carriers that you would work with in the small group marketplace that you find playing in the large group space. And many of the state-specific mandates, every state's a little bit unique, as you can imagine, but many employers or many PEOs choose to include coverage that overlaps what state mandates are, because they want to make sure that, for example, that employers have access to infertility benefits, if that's something that they want to offer to employees. So they get to make that choice, and they have that flexibility within the offering in the large group setting to include those levels of benefits.
Okay. I mean, obviously, there's a lot of mandates we've put in for a very good reason. So, I mean, I'm not trying to be flippant about it. I just trying to, I mean, if maybe it's something we can get into a little further, but this does seem like it'd be something that would really help. And it's something businesses, I think, have asked for, especially the small ones. So anyway, thank you very much.
Senator, from working on some of the ERISA legislation in previous years, where the committee and the General Assembly has given tremendous deference to those employer sponsors for those plans. It would be a similar situation here for them to kind of negotiate on behalf of their employees.
I don't see any further questions. Thank you very much.
Thank you.
We do have two unfavorables, Kimberly Robinson from Care First and Kevin O'Toole from the National Association of Benefits Insurance Professionals. So if you'll come to the table, please.
All right, good afternoon, everybody. I'm Kevin O'Toole. I am with the National Association of Business and Insurance Professionals. In my professional life, I'm a broker and a licensed advisor to businesses across Maryland, as well as DC and Northern Virginia. Today, a lot of what Senator Feldman brought up speaks to a little bit of my testimony here, but really we have spent the majority of our efforts in protecting the Maryland small group since 1993 when it was enacted, and have successfully resisted numerous attempts to make exceptions and carve out since 1993. Today being no different. The issue of adverse selection has been raised a number of times, and that's really where I want to focus today. PEOs can be great solutions for companies for a variety of reasons. Payroll, all-in-one solution, everything along those lines. They do underwrite groups coming in. So not everybody is going to have access to a PEO, even if they can afford it. If they're unhealthy, they're not going to be able to get on their benefits plan, which will leave them in the Maryland small group, causing adverse selection and rates to rise for all of those who are not able to enter the PEO. The other issue I'd like to bring to the committee's attention is even if somebody enters into a PEO, once they start having a high claims utilization, the PEO can essentially kick them out. And as soon as they become unprofitable, return them to the Maryland small group. So I think that's an issue that I've seen unfold in other states with clients that I directly work with and should be of note for the committee.
Kim?
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield, respectfully in opposition to the legislation. You just heard my colleague at the table talk about adverse selection, and we've heard that a lot in the committee, and I don't know that we've really talked about it a lot as a committee in quite some time, but when we're looking at the context of the small group market and what's happening with this bill, as you talk about people coming out of that market because they can go into a PEO, that PEO can underwrite, which, as the previous panel said, means they're not necessarily picking a person here or there out of the group. They can just say, we won't take your entire group because of your health profile. And so that PEO is not an option to groups that have a sicker, more costly health profile as part of what their employees are going to reflect when they do that underwriting. As a result, those healthy groups are who stay in the small group market. When we talk about insurance pooling, the reason why we call it a pool and why we want everybody in the pool is because you need the balance of the healthiest and the sickest all together to help mitigate what that cost is going to be. If you're healthy, leave your pool, and your sickest members are who stays, your prices continue to skyrocket as their healthcare needs go up. And so we do care about what happens with this market. I think it's why you see concern from the Maryland Health Benefit Exchange and the MIA, because anything that erodes the health of the small group market harms those employers who can't get their way out, who like how Maryland regulates, who like what Maryland requires that they get that they may not get in another product, but also those who cannot find their way out unless they shuttle employees who have higher health care costs. Part of why Maryland did small group reform was to prevent that from happening. All of these things become a risk to the constituents that you care about, who are in fact the backbone of our regulated market. That 18% does not include your largest employers. That's true. They are ERISA plans. They can self-fund. They're not part of this. It is your individuals and it's your small groups who are in that 18% who you are regulating for in the decisions that you make, and we're concerned with what this bill may do. And with that, we urge your unfavorable report.
Thank you. Do I have any questions for Kimberly or Kevin? Senator Kramer.
Madam Chair. So, Kimberly, let me ask you this.
Sure.
You make this point of a balance of the healthiest and the sickest, and without that balance, prices skyrocket. What has been the experience in the 47 states that are already doing this? Has that been their experience, that there was this huge skewing of costs and prices skyrocketed? Because I would think that they'd have pulled back from participating in this structure if in fact that was the circumstance. So do we have, you've got 47 states to sample. Where have we seen that happen, and where has states pulled back from this kind of product line?
Thank you for the question, Senator Kramer. So I did attempt to try to figure out if I could give a specific answer to a question like that, and I think the MIA did the same when they did their study. In looking at where other states are, it's hard to go back and identify exactly where every state began to have PEOs in their market. There are 2 states who are the most recent to have done it, but they haven't done it long enough for there to be data, because I think they would be your best exemplar. Both Kansas and Ohio began to allow PEOs to underwrite health insurance in 2024. So they started in 2024. 25 would have been their first plan year. I don't believe that that's long enough for them to have calculated to see what that impact was in those states. So unfortunately, where I think the best look is going to come from are the ones who've done it most recently, who are doing it in this current healthcare environment with where we are with the federal government. But at the same time, also noting that every state has not done the same kind of small group reform that Maryland has done. So there are still going to be things that are going to be different here than even in those other states.
Why would the 2 most recent states, being Kansas and Ohio, be best reflective of what we could anticipate in our marketplace? Because then there's still another 45 states out there that are doing it in this environment, in this marketplace, and you've got 45 other states to look at, because you're indicating, well, it'd be best to look at the 2 that did it most recently, but we can't look at those 2 because they did it too recently. So what about the other 45?
So trying to identify when the other 45 started is what was the first challenge, to figure out where to find their data about what life was like before and what life was like after. not being a national company who has a counterpart there, it's a little harder to go suss all of that out if it's not something the state has chosen to study for itself.
Can you
right?
compare their rates to our rates and be able to say, okay, Maryland has not welcomed
we can.
PEOs into the marketplace, and look how much better our rates are than these 45 other states that have done so. So rather than trying to identify, was there a change from within their own market space, how about comparing it to our market space?
I
So
think
in
if you're
other
gonna-
words, hey, look, here are these 45 other states, and look at their premiums compared to what it is here in Maryland. We are so much smarter to be one of the 3 states that aren't doing this, and maybe justify it. I mean, I understand, from your perspective, it's competition, and you're here to represent the best interests of, your industry and try to keep the competition out. But I'm just wondering, are we in a position to take a look at, hey, there's fact here. We are so much better off not doing this because look at the pricing.
I think the hardest part of comparing Maryland to other states is that Maryland does regulate its small group market differently than other states. And so there's not going to be an exact apples to apples comparison, just to level set, because of the way Maryland has chosen to do its small group reform. So there's already uniqueness that's never going to give you a true apples to apples comparison. I think we could endeavor. I'm not sure how the MIA undertook its comparison and why it found itself, its inability to be conclusive about it, if it was because of the difference in the way the markets are structured or something else. I think it would be interesting to just confer with the department to see how they came to that conclusion as a starting place. Certainly, you can look at just what the price tag is, but I promise you it will not tell you the whole story.
Okay.
And for the record, we can sell in any market, right? If this bill were to pass, there's nothing that says CareFirst could not now sell in the PEO market. What we also understand, however, is the consequence to the small group market that you already have. And for those businesses who cannot participate.
No, Kimberly, thank you.
What that's going to do for them.
You answered my question. Thank you very much. Thank you, Madam
Thank you.
Chair.
I don't see any further questions. Thank you both very much. Now we're going to go to Senator Kramer. Senate Bill 521, health insurance material changes to provider networks. You're going to bring up Marie Grant. She's going to have David Cooney and Marie Quay with her for questions. And then we'll have Jake Whitaker from the Maryland Hospital Association and Stephanie Clapper from the Maryland Citizens Health Initiative.
Dan Doherty's here if he wants to come in. Hi there. Thank you, Madam Chair, Mr. Vice Chair, and good afternoon to members of the committee. Ben Kramer introducing Senate Bill 521. And colleagues, I want to begin by quickly reading a paragraph from an email that I received back in September of this year. And in it, it was a constituent who sent me the following. I would like to inform you of a very serious situation with my granddaughter's health in light of the United Healthcare Johns Hopkins debacle and disintegration of coverage agreements. She suffers from celiac disease and a much more serious condition, chronic pancreatitis. She has been under the care of a doctor at the Pediatric Pancreatic Center at Johns Hopkins and may need a very complex surgical procedure. The procedure and post-hospital care would cost several hundreds of thousands of dollars in out-of-pocket liability and can only be performed by a very few surgeons in the U.S. and none in Maryland other than at Johns Hopkins. Similar situations must apply to many other Marylanders. And that was the comment from the constituent who sent me this email. And colleagues, it certainly did apply to many other Marylanders. In fact, thousands of other Marylanders, and I'm confident many of whom resided within your legislative districts. Senate Bill 521 is about protecting patients when powerful institutions have a contract dispute and ensuring Maryland families are not used as leverage in negotiations between multi-billion-dollar health systems and multi-billion-dollar insurance companies. When a provider network and an insurer terminate their relationship, it is not the executives who suffer the consequences, it is their patients. Seniors in active cancer treatment, children in specialty care, families in the middle of pregnancy, and individuals managing complex chronic conditions. We saw this most recently in that dispute I just referenced between Johns Hopkins Medicine and United Healthcare. Thousands of Marylanders suddenly faced uncertainty about whether their doctors would remain in network, whether their surgeries would be covered, and whether their treatment plans would be interrupted. And they also wondered whether they could afford to continue care with the physicians who were the most familiar with their circumstances. This is not a partisan issue. This is not an anti-insurer bill, and it's not an anti-provider bill. It is a patient protection bill. SB 521 establishes clear, fair guardrails when contract negotiations break down. Advance and meaningful notice to patients will be provided, and not confusing letters sent at the last minute. Robust continuity of care protections for individuals in active treatment are provided. Clear cost protections so patients are not exposed to unexpected out-of-network bills during their transition period, and transparency requirements so consumers understand their options before decisions are forced upon them. In Maryland, we regulate the insurance market to protect consumers. We license providers to ensure quality. But when these two systems collide in a contract termination, patients often fall into a regulatory gap. Senate Bill 521 helps to close that gap. We cannot prevent every business dispute, but we can prevent Marylanders from being collateral damage in those disputes. Patients should not lose access to their cardiologist because lawyers cannot agree on reimbursement rates. A child should not have to change specialists in the middle of chemotherapy because two corporations are negotiating market share. This bill provides that when negotiations fail, patient care must remain stable. Maryland has long been a national leader in healthcare innovation and patient protection. Senate Bill 521 continues that leadership by placing patients, not profit margins, at the center of our healthcare system. And Madam Chair, before I turn it over to the panel, I would like to extend my thanks to both Commissioner Grant and Ms. Jamie Sexton for their help in dealing with this issue when my constituents found themselves in this horrible position of being collateral damage because of the Hopkins United Healthcare debacle. They were outstanding in ensuring that those people who needed the continuity of care did in fact receive it. And I thank them also for all the work they did in helping prepare this legislation so that going forward, once again, we put patients first. Thank you, Madam Chair.
Senator, I want to thank you for complimenting our insurance commissioner. We just had this conversation on the prior bill. She and her department are so important to the health care coverage of our insureds. Thank you.
100%.
Thank you so much, Madam Chair. Senator Kramer, let me first just say thank you for introducing this very important bill, Senate Bill 521. As the sponsor indicated, this is a bill about keeping patients out of the middle when provider disputes occur. In Maryland, we've been pretty lucky. In part because of our all-payer rate setting system, there's not been as much to fight about between hospitals and insurers. But unfortunately, we saw some of that break down this year. And unfortunately, I would love to be wrong, but I have a concern that in a world of shrinking resources, we may see more of these fights, which makes this bill and passage of this bill even more important. This bill does a few really important things. I think, first of all, it expands continuity of care protections. Right now, we have continuity of care 90 days for primary care providers in Maryland. This expands that to behavioral health in addition to primary care. It requires insurers more proactively to tell us when they think someone is going to go out of their network and it's going to impact their network adequacy. That's not on the books today. This gives the Maryland Insurance Administration more tools to make sure that our insurers have adequate networks if there is a contract dispute. And then for health systems, there's some specific requirements about holding coverage in place for 90 days. In the United Johns Hopkins situation that we saw, there was continuity of care for specific conditions. There was a lot of confusion about how to request it. There was confusion about what qualified and what didn't. This would just say 90 days. We're staying in network, and that will give our patients and consumers time to figure out future care should it not be in network with a health system or provider. And finally, the bill allows for a special enrollment period in the individual market. Folks buy their plans thinking their provider is going to be in network. If that provider is no longer in network, they should have the opportunity to shop around. So urge a favorable report. Thank you again to the sponsor for his support, and thank you all. Happy to answer any questions.
Mary, would you like to add anything, or you're just here for questions?
Here for questions.
Thank you. Stephanie?
Chair Vital, Vice Chair Hayes, and members of the committee, thank you for the opportunity to submit supportive testimony in favor of Senate Bill 521. I'm Stephanie Clapper, Deputy Director at Maryland Citizens Health Initiative, and our mission is quality, affordable health care for all Marylanders. And this legislation would provide much needed protections for consumers when there are disputes between large healthcare systems and insurance carriers. These protections are critical so that consumers have the time and flexibility to, in the case of a big dispute, either transition their care to new providers or choose a new plan to maintain their provider access if they were enrolled in individual market coverage. Without these protections, as we have seen, consumers may have to go without the health care that they need, which can have devastating health consequences. We urge a favorable report for Senate Bill 521, and thank you for your leadership.
Jake?
Great. Thank you, Madam Chair and members of the committee. I'm Jake Whitaker, and on behalf of Maryland's hospitals and health system, here in strong support of Senate Bill 521. Hospitals see firsthand the challenges insurers cause when they remove providers with just little or no warning. So when a patient, excuse me, when a patient's primary care provider or behavioral health provider is suddenly dropped, hospitals really bear the fallout. Patients show up confused, without continuity of care, or worsening chronic conditions simply because they couldn't find a new provider in time. This drives up avoidable ED visits, delays in treatment, and frustration for patients and hospital staff. SB 521 would give hospitals the predictability they need to support safe operations. Advance notice of network changes allows hospitals to adjust staffing, scheduling, and care coordination. Sudden network disruptions affect inpatient discharges, outpatient follow-up, and referrals, all of which impact ED wait times and patient flow. So with early notice, hospitals can help patients transition more smoothly and avoid unnecessary complications. And really, this is a continuity of care and patient safety issue, and this bill really supports it. So allowing patients to continue seeing a terminated provider during this transition period prevents dangerous gaps in care. So we can avoid these consequences when the care is abruptly cut off for things like uncontrolled diabetes, unmanaged health conditions, delayed cancer follow-up, as well as medication lapses. And so this bill will help avoid some of those avoidable emergencies. And finally, this bill creates accountability and transparency between both insurers and hospitals. So hospitals can't plan around payer decisions that occur without notice. So requiring both sides, the insurers and the health systems, to give advance notice before terminating a contract will just help create continuity and stability across the healthcare continuum. So for the aforementioned reasons, we respectfully request a favorable report. Thank you, Madam Chair.
Jake, I don't see any questions.
Madam Chair, and if I may very quickly to your point a moment ago, in my 20 years in this legislature, there has never been a more accessible Maryland Insurance Administration than we have right now. So to your point, this is an outstanding commissioner and an outstanding office.
I agree, Senator, because she started in the legislature and got trained in the finance.
And there's that.
Thank you very much, Marie. All right, that ends this panel. We have one more person to speak. Dana Kaufman is going to favorable with amendments from MedChi.
I too started in the legislature. For the record, Dana Kaufman on behalf of MedChi. We support the bill. Our written testimony does have 2 amendments, but since I actually drafted that, we've been in discussions with the MIA and recognize that those provisions are probably better for another day discussion. So therefore, we do support the bill and we ask for a favorable.
Cross out my note on MedChi's amendments. Thank you very much, Dana. I don't see any questions. Thank you. Thank you for being here. That ends the hearing on this Senate bill, and we're going to go to Senator Augustine, Senate Bill 774, Health Insurance Plan Benefits and Coverage. And he is also going to bring up Marie Grant.
Yes.
Ann C. Cott and Jamie Sexton.
Yep. Hello. I'm good. Great. Thank you, Chair Bidel, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 774, the Truth in Mental Health Coverage Act. Colleagues, data collection and transparency is vital for improving access to mental health and substance use disorder care. Much of the data required under this legislation is already required or available, and thus it really is kind of a minimal burden for health plans with significant implications for consumers and employers to really be able to understand their coverage and take advantage of their rights. This piece of legislation is really about transparency. It's about making sure that we are able for folks to be able to really be able to make sure that we're getting parity in the care that they're getting between somatic and behavioral health care. And myself and other folks have worked very closely with Commissioner Grant to make it something that helps the MIA to do their job and is beneficial to the public. And so we've worked on some amendments, which I've been asking for. They're on their way, and I'll absolutely share them, but those are things that we've worked together on. And Madam Chair, I'll just turn it over to Commissioner Grant, who I've partnered with on this, and ask for a favorable report with the amendments that we have coming.
Thank you so much, Senator. Madam Chair, Vice Chair Hayes, committee members, Marie Grant, on behalf of the Maryland Insurance Administration, just here to express our support favorable with amendments for Senate Bill 774. As Senator Augustine mentioned, and as an administration, we're interested in being as transparent as we can, sharing information with folks to help understand their health coverage. And this particular bill has a number of places where about data sharing over time that will help consumers understand their coverage. We've been working on some amendments that do a couple of things. First of all, the bill as introduced has some pretty specific language about interactive data dashboards, things that we would need to get up and running. So amendments would address some flexibility with the operations. And then we want to make sure that the things we're reporting out on coverage are meaningful and understanding for consumers. And so we've been working on some language within regard to that. But again, look forward to sharing those amendments with you and happy to answer any questions.
Ann?
Madam Chair, members of the committee, I'm Ann Seacott, testifying today on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence in strong support of Senate Bill 774. This bill is about public transparency. Studies show that people in Maryland have to go out of network for substance use and mental health disorder treatment at much higher rates than folks in other states. This is just one data point, one example of how consumers and employers would be better able to choose their health insurance plan if they were able to access some of this data that would demonstrate some of these access points. By making certain that data is available on their website, the MIA would be able to give consumers and employers greater information as they make decisions on what healthcare plans to purchase. We're really grateful to the sponsor, to the MIA for working with everybody on amendments, and we ask for a favorable report.
Thank you. I don't see any questions for this panel. Thank you very much.
Thank you.
We have one virtual. David Lloyd, is he there? Okay. Mr. Lloyd, will you unmute and give your testimony, please?
Thank you, Madam Chair and members of the committee. I'm David Lloyd, Chief Policy Officer at Inseparable, a national nonprofit working to close the treatment gap for people with mental health and substance use conditions. Inseparable testifies in strong support of SB 774, the Truth in Mental Health Coverage Act. Across Maryland, families are told that mental health and substance use services are covered by their health insurance, but when they try to use that coverage, too often they encounter delays, denials, and an inability to find in-network providers. When people can't access the timely mental health and addiction care that they paid for, the consequences ripple across our entire healthcare system, driving up total healthcare costs 2 to 6 times higher due to preventable costs like emergency department visits and hospitalizations. Currently, these costs are frequently shifted onto Medicaid and other public programs. The Truth in Mental Health Coverage Act addresses this problem by bringing urgently needed transparency to how mental health coverage actually works. The bill requires insurers to report standardized data on key areas, including denial rates, out-of-network use, provider payment levels, and network participation. This data, much of which is already collected by MIA, would be made publicly available so that consumers and employers can compare insurers side by side. Importantly, this bill does not mandate new benefits or set reimbursement rates. It simply brings transparency on whether coverage equals access. Inseparable believes that when insurers must compete on access, Maryland families and employers win. We respectfully urge a favorable report on Senate Bill 774. Thank you.
Thank you, Mr. Lloyd. I don't see any questions. That ends the hearing on Senate Bill 774. And Senator Augustine's going to come back and do Senate Bill 738 and bring with him Ann Seacott and Dan Rabbit.
Yeah. Thank you, Chair Bidel, Vice Chair Hayes, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 738, Maryland Medical Assistance Program and Health Insurance Required Coverage, Mobile Crisis, and Crisis Stabilization. Colleagues, we have worked so very hard on getting better behavioral health outcomes, and to do so with early intervention so that we were able to have really better health outcomes, but also we're able to bring down the overall cost of cost, and those overall costs, being able to bring overall costs down for behavioral health, but also for somatic care as well, because we know that those things oftentimes they will work together. And what this piece of legislation does is that it really builds on the work that we have done in supporting 988. And we've created 988, or not created, but we've uplifted 988 in our state. But there is that second step for those who are in a crisis, then there may be a need for an intervention. And that is the infrastructure that we have been building as it relates to mobile crisis and crisis services. It's that next level. And it's just a way more affordable way for us to work with folks versus having people make their way all the way to the much higher intensity, like hospital stays and things like that. So we really want to get to support them sooner and earlier. And there is this model that is proven, that works, which is these interventions with mobile crisis and mobile crisis teams and crisis services. So we know it works. We have been working on it, using it. But what the issue is, the challenge that we have with these services is that right now they're really supported by grant funding, both at the state level and at the federal level, which is great from a demonstration standpoint, but it's simply not sustainable. It's just not sustainable. And so what this piece of legislation does is says that what we should have and what we need to do is we need to move into this as a covered benefit for Marylanders, so that we move it up front instead of folks getting into the emergency rooms because they aren't, where we end up paying for it on the back end anyway. And then we get these much greater health outcomes. And that's what this does. So right now, the state has already made the decision as it relates to their Medicaid that they will cover it. So the state is already doing that. And there are some things where we got to change some language, which is fine, but the state is supportive of this piece of legislation. Now what we're saying is, okay, let's also ensure, and there's a significant number of the people who are a part of this do have state covered insurance. There's no question about that. But what this piece of legislation says is that right now, when people are coming into these services and we're serving them, if they are also using commercial insurance and stuff like that, that needs to be covered. I mean, we got to figure out a more sustainable way to get this covered going forward. And that's what this piece of legislation does. What it says is that we're going to require this coverage for mobile crisis and crisis stabilization because it will, in the end, pay off for us in the long run in both keeping people, helping us with some of our emergency rooms. When we expand this service, we get it further, deeper into our state, it will help us with some of the those emergency room visits and overall cost of that really higher cost acute care. The last thing that I will say to the committee about this is that there's real evidence in the written testimony that shows that it will in fact save us money. So you can look at the written testimony on dollars that have been saved in states like New Jersey and Connecticut, where you have this utilization studied out, peer reviewed, that shows that that is the case. And then I'll also say we live in obviously this region. And part of where this came from for me is that Virginia is covering this. So Virginia passed legislation that says that both the public and the private, and we are, our carriers, they cover across the board here. So our carriers are already doing this. The public and the private are covering mobile crisis and crisis services. And what I'm asking for is for Maryland to do the same as a part of this entire continuum of care, that this is an important element. And I'm going to ask for a favorable report on Senate Bill 738. Thank you.
Thank you. Dan?
Good afternoon, Chair Bidle, Vice Chair Hayes, members of the Senate Finance Committee. For the record, my name is Dan Rabbitt, Policy Director for Behavioral Health System Baltimore. We are the local behavioral health authority in Baltimore City and in strong support of SB 738. Behavioral health crisis services are essential, and we have recognized in the state that our traditional emergency response system, 911, EMS, law enforcement, emergency department, is not the appropriate way to handle mental health and behavioral health crises. We need a system that's designed to respond to those specific sorts of needs. And we've worked really hard to have that in Maryland with 988, with mobile crisis teams, and with crisis stabilization centers. BHSB, we've been really involved in building that out in the greater Baltimore area. You may recall a project called GBRICS, where we got grants from the HSCRC to build a stronger crisis system. And those grants were great. And that project had wonderful results in reducing emergency room visits. But the trickiest part of that is sustaining it. We've worked hard. We've established the 988 Trust Fund with the 988 telecom fee for sustainable funding for 988. We have Medicaid reimbursement for mobile crisis teams and crisis stabilization centers. But those two funding pots, with the grants going away, make it still challenging to sustain the level of crisis response services we need in Baltimore. Bringing private payers into the mix would help to provide the sustainable funding we need. And that's just in Baltimore. In other parts of the state, they have a lower coverage rate for Medicaid and a higher proportion that is private coverage. So it's really essential to incorporate private insurance reimbursement into the funding mix. These services are not optional. They're not only for lower income households. So private insurance really should be covering them the way they would ambulances or emergency departments. It's reasonable and absolutely necessary. So we ask for a favorable report.
Thank you, Madam Chair, members of the committee. Ann Seacott testifying in support of Senate Bill 738 on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We know Maryland continues to experience a greater need for behavioral health services than we're able to meet. We know that you all have done a lot to try to meet those needs, but there are still gaps in coverage. SB 738 proposes to address part of this gap by mandating that both Medicaid and private insurance cover crisis services. As the fiscal note describes, $1.5 million in just fully annualized in general funds will be saved instead of spent by the state, specifically on services that are already paid for by, or specifically by the carriers for people who are already contributing through their premiums for insurance coverage. So that's very significant savings, especially when we look at what the overall budget picture is this year and the next couple of years. Medicaid coverage of crisis services will also save money as we are doing earlier interventions and avoiding more in-depth expensive services. There was a report put out by the Attorney General just in January that cited data that nearly 1/4 of all people killed in officer-involved deaths in Maryland are in a behavioral health crisis. We must have more resources in this space so people with expertise in de-escalating situations and addressing mental health issues and people in crisis situations have access to timely, appropriate services. This bill closes some of that gap, and we urge a favorable report.
Thank you. I'm going to go a little off record here, or off the topic. Dan, if you could answer something for me. I found out that our mobile crisis center mobile unit in Anne Arundel was ordered this week to handcuff everyone. Do you know if any other jurisdictions are doing that?
What do you mean by handcuff everyone?
When they go on a call of someone that's in a behavioral crisis, they have to handcuff them to transport them.
That is not required unless it's an emergency petition where someone's being involuntarily committed. Yeah. That's a choice.
It's a problem.
Yeah, yeah.
I just wondered if you knew if other jurisdictions were doing that.
And that's like the co-responder model where there's a social worker and a police officer going out.
Right. That was.
So the whole idea of that is for it to be more trauma-informed, and getting handcuffed is not.
Thank you. Thank you for helping me with that. Any other questions for this panel? Nope. Thank you very much.
Sure. Thank you, Senator.
Now we have Mary Ann Gibson from Inseparable. She's going to testify favorably.
Chair Beidel, Vice Chair Hayes, and members of the committee, thank you for the opportunity to testify today in support of Senate Bill 738, which will expand insurance coverage for crisis services. I'm Mary Ann Gibson. I'm here on behalf of Inseparable, and we are a national nonprofit mental health advocacy organization. We all know that the behavioral health needs in Maryland are significant and well documented. 20% of Marylanders have experienced a mental illness in the past year, and ensuring that our state has a coordinated and sustainable crisis system is critical to meeting that need. Mobile crisis and stabilization services are essential components of our behavioral health crisis system. Mobile crisis teams respond to individuals in the community experiencing crises in a timely and clinically appropriate manner. And oftentimes, these teams are able to stabilize individuals without the need for emergency department visits or inpatient hospitalizations, which we know are more costly. Conservative estimates say that they're 20% less expensive than hospitalizations. And this matters because mobile crisis care is less expensive than care delivered in EDs. It reduces the strain on overcrowded hospitals, but most importantly, it allows individuals to receive care in appropriate settings for them. However, our crisis system does face a structural funding challenge. Many services are primarily supported through more variable funding streams like federal grants and state general funds. These funding sources are vulnerable to budget pressures, which makes sustainability difficult. And Senate Bill 738 takes a meaningful step forward by requiring both commercial insurance and Medicaid to cover mobile crisis and stabilization services. By establishing insurance coverage, this bill would help diversify and stabilize funding for our crisis response system. We've made such significant progress in building out a system that serves people in their communities, and this bill helps ensure that the financing model will keep pace. And for those reasons, I respectfully urge a favorable report for Senate Bill 738.
Thank you very much. Do I have any questions for Mary Ann? I don't see any questions. Thank you for your testimony. That ends the hearing on 738. We're going to go out of order a little bit. We're going to have Senator Lamb on Senate Bill 795. And Senator, I'm going to call up your panel, I think. Something's out of order. You have Delora Sanchez, Felicia Porter, and Catherine Carter as your panel.
Yep. Okay. All right. Thank you, Madam Chair and members of the Senate Finance Committee. For the record, Clarence Lim, Senate District 12, here to present SB 795, which is on vision benefits and the regulation of insurers and vision benefit managers. The origin of this legislation goes back to 2013 when both chambers of this legislature unanimously passed Senate Bill 904, which was on vision services provider contracts, which included the regulation of VBMs in Maryland insurance statute. Vision benefit managers are third-party companies that are utilized by insurers to administer vision benefits, determining covered services, rates, and provider networks. Unfortunately, the intent of the law has not been fully realized since its passage back in 2013. With the exception of one VBM operating in Maryland, none are registered insurers with the Maryland Insurance Administration. Without government or regulatory oversight, anti-competitive vision benefit manager practices have resulted in huge profits, which have enabled these entities to dominate the market. More than 27 states have passed some type of legislation to address VBM unfair practices. These premiums have not increased in any of these states. This bill, Senate Bill 795, ensures that the intent of the original 2013 law is achieved and provides additional protections to improve access to quality eye care at affordable prices for all. Today, roughly 200 Marylanders, 200 million Americans receive their preventive eye care exams and materials through vision benefit managers. Two dominant companies control approximately 2/3 of that market. The level of concentration alone is particularly concerning, but the issue here is not just market share, it's also vertical integration. You will hear from several optometrists today about how this has affected their ability to care for patients. VBMs increasingly own multiple layers of vision care systems. They include the insurance product themselves, frame manufacturers, lens laboratories, retail clinics, electronic health systems, and in some cases, even the practices themselves. This vertical structure allows them to steer patients towards affiliated products and services, often through pricing design, reimbursement policies, and provider incentive programs. At the same time, reimbursement rates for doctors of optometrists, have remained largely stagnant for years. In Maryland, rates have not changed since the 1990s, even as their practice costs have risen substantially over the last couple decades. Often, doctors operate at a loss to see their VBM patients. In some cases, doctors are offered higher reimbursement only if they agree to use VBM-owned frames, lenses, and software systems. This creates a significant imbalance of power. When a company controls the insurance network and the supply chain and can influence a provider's inclusion in that network, independent practices have very little negotiating leverage. Exclusion from a dominant vision benefit manager network can threaten the viability of a small business practice and also limit patient choice in local communities. Allegations that these dynamics are being used to impose tying arrangements and other restrictive competition efforts are the reason that the U.S. Department of Justice and the U.S. Government Accountability Office have both opened investigations into vision benefit managers. Whether through acquisitions or contractual language, the cumulative effect is reduced transparency, reduced competition, and ultimately higher costs for patients from whom you will hear today. This bill is about enhancing patient choice. Some VBM contracts require enrollees to select from limited options such as frames from a company that VBMs own. They may require enrollees to select from lenses from a laboratory that the VBM also owns, and limits the provider to use specific sources and suppliers of covered or non-covered materials, which limits competition and the choice for enrollees, and ultimately also interferes with the doctor-patient relationships that occur. VBMs sometimes limit patient decisions with an exclusive offer of sorts. This exclusive offer is only available to patients visiting the VBM-owned retail optical outlets, leveraging financial incentives to steer patients from other participating in-network doctor locations. We urge your support of Senate Bill 785 to address the ever-growing consolidation and also vertical integration in the vision care market to ensure that independent doctors and optometrists can compete fairly and that patients retain meaningful choice. Big business should not dictate patient care. Senate Bill 785 protects patient choice and the doctor-patient relationship with their optometrists. With that, thank you to the committee. Let me turn over to other members of the panel and then take questions at the end.
Thank you, Senator. Who would like to go next?
Good afternoon, Chair and Vice Chair and members of the committee. My name is Kat Carter. I am president of the PTA Council of Howard County with over 10,000 members. I'm speaking today on behalf of Free State PTA, which supports this bill. Free State PTA represents more than 70,000 members across Maryland who advocate for the health, safety, and success of our children. I also want to share that the Howard County Education Association, representing more than 6,300 educators, supports SB 795. Our teachers have personally donated thousands of dollars of their own money to provide eye exam vouchers for students because they know firsthand the impact that not having access to an eye doctor has on a student's ability to learn. I am also a small cybersecurity business owner, former English teacher, Lions Club member, and mom of 5. As a small business owner who purchases my family's vision insurance on the open market, I am here today as a parent and as a patient in support of this bill. All 5 of my children and I wear glasses or contact lenses. In our household, vision care is constant. My daughter is currently in myopia management treatment to slow the progression of her nearsightedness. Progressive myopia significantly increases the lifetime risk of retinal tears and retinal detachment, so this treatment helps protect her eyesight for decades to come. During one period, her prescription changed rapidly, and we had to pay out of pocket because waiting was not an option. This issue is deeply personal to me. My son Atticus once struggled with an undiagnosed double vision and could not keep the words on his page long enough to read. His experience helped inspire the Atticus Act in Maryland because students must be able to see to learn. SB 795 continues that work. And in addition, the blueprint of Maryland's future shows significant concentrations of poverty fund being spent. I'm asking you to pass this bill because it helps small businesses and families like mine and the thousands of Maryland children who need an eye doctor so they can see to learn. Thank you.
Thank you. Delora.
Good afternoon, Madam Chairman, members of the committee. Delora Sanchez-Ificalche with Cornerstone Government Affairs on behalf of the Maryland Optometric Association. I want to talk a little bit about what you're going to hear from opponents on this legislation. One of the talking points that we've heard here and certainly across the nation where we've seen this legislation is that VBM or Vision Benefit Manager is a made-up term. Well, all terms are made up, but setting that aside, like PBMs, in most cases, VBMs are third-party administrators that act as middlemen between insurers or providers to manage benefits. VBMs act like PBMs by lacking transparency in business practices and creating a tremendous imbalance of power. The VBM concept is defined by monopolistic control, where VBMs impose one-way contracts or contracts of adhesion that force independent doctors to use VBM-affiliated labs that cost up to 50% higher than market rates. They don't like that categorization, but it fits the archetype, which many of the same concerns we saw before this body stepped in to correct similar business practices. You'll also hear it's too hard, it's too burdensome, or we just don't want to do it. This body can and has done hard things. Sometimes it takes longer than we might like, but providing guardrails around VBMs to increase access and create fairness can and should be done. I also talked briefly about the increased cost argument. This bill will reduce artificial lab costs. VBMs often force doctors to use affiliated labs that charge up to 50% more than what a doctor could negotiate with a local lab. These higher costs are passed on to consumers. While premiums may be low, out-of-pocket expenses for patients are actually rising because of dwindling benefits and significant upselling by VBMs. Patients often find it cheaper to pay cash at a local lab than use their insurance benefits. And with that, I'd ask for a favorable report. Thank you so much.
Senator, I don't see Felicia Porter, Councilwoman Porter. Did she leave?
She did have to leave, unfortunately.
Okay, I'm sorry. Thank you very much for your testimony. Do I have any questions for this panel? Okay, seeing none, we're going to go to some other favorables. Perry Lucente, Vicky Wong, Heather Atchison, Nudaporn, I won't even attempt that last name, Jennifer Cohen, and Mark Gordon. Okay, who would like to start?
Thank you for your time today. My name is Vicky Wong, and I'm an optometrist and a small business owner in Rockville, Maryland. All the doctors here today are here despite the concerns of being blacklisted. Retaliation has been a precedent in California, but I wanted to bring about a growing concern about these VBMs, such as VSP and IMED. Patients often assume that their doctors are involved in all aspects of their eye care and purchasing options. But what they don't realize is that after we verify their benefits and pull an authorization through that VBM, they may be targeted with marketing emails from that VBM. The sequence that we are experiencing is concerning. The patient schedules with our independent practice, we verify their benefits and pull an authorization, and then shortly after, that patient will receive marketing emails concerning that are encouraging to purchase eyewear online with those affiliated retail locations. We've had a patient physically standing in our office get an email on their phone about using their materials benefits at Iconic, one of VSP's very own entities. The timing strongly suggests that patients' benefit data is being used to trigger anti-competitive, monopolizing marketing. As independent providers, we must participate in VSP's network to remain accessible to patients whose employers are just near us and offer these as plans. As a small business owner, I reluctantly write this off as a business expense because I took an oath as a doctor to take care of patients no matter what. When a VBM administers the benefits and owns the retail competitors, there seems to be an inherent conflict of interest. At this core, this bill is about transparency, fairness, and patient choice. Patients deserve to make informed decisions free from these behind-the-scenes steering maneuvers. The independent practices, like our small business, deserve a level playing field. Without meaningful separation between benefit administration and retail competition, vertically integrated VBMs will continue to disadvantage the locally owned optometric offices like mine and the patients we serve. This bill gives Maryland providers the same protection that larger healthcare systems can actually afford to demand of these vertically integrated systems that only fragment eye care. Thank you.
Hello, Madam Chair and committee members. My name is Dr. Heather Atcherson, and I'm a second-generation private practice optometry owner in District 33 in Annapolis. For years, my father and I debated whether we could continue to afford keeping vision plans. I wanted to serve as many patients as possible. He had grown discouraged after decades of financial strain from these plans. The reality of it is simple. Reimbursement rates for comprehensive eye exams have not increased in close to 30 years. Today, it costs my practice $260 per hour just to keep the doors open. We schedule 45 minutes for every exam because that's what a comprehensive thorough eye exam requires, and yet vision plans reimburse between $40 and $60 per exam. That just does not cover the cost of providing care. Because of this, independent practices like mine are forced to rely on the sale of glasses and contacts in order to remain financially viable. We strictly follow the patient's insurance benefits. We charge only the copays and allowances laid forth by the plan to remain competitive, but the exam itself, which is the core medical service we provide, is significantly undervalued. Vision plans don't operate like traditional insurance where they do not assume unpredictable risk. They cover one routine eye exam per year and very fixed allowances for materials while maintaining control over reimbursements. The main plans have become so vertically integrated that they own a piece in every touch point of the industry, and so little independent doctors have no ability to fairly negotiate rates. While premiums have very likely adjusted to inflation over time, reimbursements to doctors have not changed. Corporate profits have grown, while small community practices like mine struggle to keep the lights on. We want to continue delivering high-quality, comprehensive care to our patients, but without meaningful change, sustaining independent practice becomes increasingly difficult. Thank you for your time.
Good afternoon, Chair and members of the committee. My name is Perry Lucenti. My wife and I represent the only remaining independent private optometry practice in Calvert County. Every other practice has been vertically integrated through private equity ownership. We began our careers 35 years ago as hospital-based providers. For 25 years, we dedicated 2 days a week to serving nursing home residents across 5 Maryland counties. Over that time, we witnessed the rise of third-party administrators, managed care organizations, and the rapid expansion of vision benefit managers following Medicaid expansion under the Affordable Care Act. Vertical integration distorts the principles of free market. Vision benefit managers use professional eye care services as a loss leader, often reimbursing below cost to drive patients towards their more profitable products, eyewear. In doing so, they blur the line between routine vision care and medical care. They require providers to bill medical CPT codes instead of wellness codes while refusing to properly coordinate benefits between vision and medical plans. Most do not meaningfully coordinate benefits at all. Patients are often forced to return for multiple visits and copays. The coordination of care should maximize patients' benefits, minimize unnecessary visits, and streamline efficiency. Current VBM models create inefficiency. Submitting a vision claim can be as complex as a vehicle purchase contract. Providers must manually transfer explanations of benefits between plans rather than rely on streamlined universal systems, often require providers to submit to a medical insurer only to obtain a denial, then resubmit to the vision plan with documentation attached. Senate Bill 795 promotes true coordination of care, restores consumer freedom of choice, reduces unnecessary administrative burdens, and supports independent providers who prioritize patient care over products. I thank you for your time and consideration.
Thank you, Madam Chair and committee members of the committee. My name is Natalie Sukantasap, and I am a practicing optometrist and small business owner here in Fulton, Maryland. I'm also here on behalf of the Maryland Optometric Association. One of the primary ways that vision benefit managers exert control is by imposing unfair contract terms and make it extremely difficult for providers to operate a small business. For example, providers are required to discount non-covered services and materials, often at a loss with no ability to negotiate. Many of these non-covered services and materials include new technologies and innovative treatments. As with any advancement, there are real costs involved: staff training, new equipment, updated workflows, and the technology itself. Just as the new generation smartphone costs more than the first model, new lens technologies, including the most recently approved to slow progression of nearsightedness in children, require significant investment. For services and materials not covered by the plan, providers should have the ability to set their own fees and decide whether to offer that discount. This flexibility allows small businesses to account for the true cost of delivering care. Additionally, provider contracts often restrict our choice of labs and suppliers, both covered and non-covered materials. Many optometry practices, like myself, have in-office finishing labs that allow us to provide faster service and negotiate better pricing for our private pay patients. However, for vision plan patients, we are required to use designated labs. I currently send vision care orders to Tennessee, New York, Texas, despite 3 full-service opticals right here in Maryland. By allowing providers to choose their labs will strengthen local business and support Maryland's economy. In closing, SB 795 restores fairness and transparency to the vision care market. It ensures fair provider contracts and protects patient choice. Thank you for your time. Happy to answer any questions.
Good afternoon, Madam Chair, members of the committee. My name is Jennifer Cohen, and I am the Executive Director of the Maryland Optometric Association. I've submitted written testimony, so I'm just going to share that I've been with Maryland Optometric Association since 2011. That was right after the ACA. And during the ACA, we made it a point, we fought very hard, lobbied very hard to get eye care incorporated into major medical. We did not want standalone plans. We did not want to be part of that, as was dental. And this is basically the reason why. Eye care was included for pediatrics, but not for adults. And what essentially has happened here with VBMs providing the care supplemented that their insurance, their major medical does not, is their anti-competitive behavior is essentially causing practices and doctors not to participate in plans. There is a really, really huge dearth in MCOs. Most providers do not accept VBMs. We do projects all the time. We did one this past year in Howard County, and we brought 125 free eye exams and glasses to Howard County students. There were no providers. There were a handful of Medicaid providers, MCO providers for follow-up. Simply put, VBMs, you're talking about the 2 VBMs own 85% of the market. One of the VBMs is VSP. They're not-for-profit, although they did lose their not-for-profit status with the FTC. The other is IMED. Can't find records on VSP, but IMED, or Essler Exotica, who is their parent, made $3.1 billion last year. So please keep that in mind and vote favorably on Senate Bill 795. Thanks.
Thank you for your testimony. Do I have any questions? Senator Mounts.
Thank you, Madam Chair, and I thank you for your testimony. The prior panel was speaking to the bill specifically, and it's an interesting topic. I'm in the doctor's office. Everybody goes in and visits with the doctor, and some of the doctors are more forthcoming than others, and they'll explain to you what you should have versus what you can have. When we're talking about this issue, can you explain some of the things that some of your patients could have but aren't able to get because of the way this insurance is working out? Whoever, I can only be one witness, and because of time and everything.
Yeah, I have a perfect example of that. I had a young 6-year-old girl. She broke her glasses that were initially bought through her VBM plan. And because the remake or that the second pair of glasses had to be done through the VBM plan, because that's what their parent could afford, we had to wait over a week for those glasses. Now, a 6-7-year-old girl, you know, vision, very, very, very important for learning, was sent to school with no glasses. And she's a -3. She couldn't see the board, you know, barely getting around and stuff, because we had to send the glasses out to Kentucky. However, I have an in-house lab right in my own office. I could have made the glasses in half an hour, but I wouldn't have been paid for it. It was my materials and everything, but we had to go through the plan because that's, again, the contract that I signed. Even if I physically could make her glasses, I wasn't allowed to. I had to use their plan.
Thank you.
Other questions? Thank you to this panel. Now we have 3 unfavorables. William Kress, Melody Healy, and Julian Roberts. I haven't seen Bill today.
Yes. Thank you, Madam Chairman and members of the committee. My name is Julian Roberts. I'm the Executive Director for the National Association of Vision Care Plans. I want to thank you for the opportunity to speak with you today. And we do stand in opposition to SB 795. Our members represent 14 vision care plans all across the country. Together, our members provide over 4 million Marylanders vision benefits. Vision care plans are highly valued by both employer and employee. In Maryland, over 1,000 large and small businesses, unions, and municipalities have chosen to offer vision benefits. First, to correct some of the comments that have been made previously in testimony that are somewhat misleading or incorrect, is that vision care plans are not like PBMs. They do not operate like PBMs. Vision care plans are voluntary benefits and provide consumers choice and transparency where PBMs do not. Comparable legislation has not passed in 27 states. In fact, probably more so similar to the legislation that passed in 2013. And some of those have been jointly supported by vision care plans in passing some of that legislation. And also, vision care plans are regulated by the MIA. Our concerns regarding SB 795 is that it includes language that contains an effective gag order on truthful communications to consumer discounts, requires unprecedented and burdensome mandatory disclosure requirements, contains unreasonable customer service mandates, decreases network adequacy, and encourage litigation while impending audits. I thank you for your time this afternoon and happy to answer any questions that you may have.
You, Melody.
Good afternoon. My name is Melody Healy, Chairman Boodle, and members of the committee. Thank you for having me here today. I'm a Senior Vice President at VSP Vision Care. I hope we all agree that keeping vision care affordable to your constituents is a shared goal. And right now, vision insurance helps Marylanders save over 50% on the cost of their eye care and eyewear. We oppose SB 795 because it will increase the cost by a staggering $500 per family. Healthcare affordability is already a significant concern. Vision insurance offers important benefits at a stable price. While medical premiums have increased by over 50% in the last decade, vision care premiums have increased by just $1 per month. In the past year, 36% of Americans avoided getting health care due to high cost. Increasing the cost of vision care is likely to have the same effect, causing patients to skip that important annual exam. That's not good for patients or doctors. Vision care is a valuable, viable health benefit that provides real savings and choice for your constituents. Their coverage allows them to see any provider, select any frame, and get any lens on the general market. Our members in Maryland, including electricians, hospital workers, and city employees, expressed 90% satisfaction with the benefits in 2025. SB 795 hurts consumers by increasing premiums, copays, and out-of-pocket costs, keeping patients in the dark about practices and products that provide the best value for their individual budgets. We respectfully request that SB 795 not move forward. Thank you for your time, and I'm happy to answer any questions.
Thank you. I don't see any questions. Thank you both for your testimony. And that ends the hearing on Senate Bill 795. Next, I think Senator McCray is here. We're going to do Senate Bill 699, health insurance, physical therapy, co-payments, co-insurance, and deductibles. And Senator McCray, you have Dan Shattuck with you, right?
Yes, ma'am.
Okay. Is this more of your panel?
I believe so, and if they can state their names.
Hi, I'm Roy Film, APTA Maryland President.
Okay, and you're Linda Horn?
Linda Horn.
Okay, thank you.
Yep. Thank you, Madam Chair, members of the committee. I come to you for the record, Corey McCray, Senator for the 45th Legislative District, and just come to you in reference to Senate Bill 699, Madam Chair. What Senate Bill 699 would do is just prohibit the insurers from applying a copay, co-insurance, or deductible to physical therapist services that are greater than the copay, co-insurance, or deductible for a physical or wellness visit, Madam Chair. This will bring down the high cost of copays, confronting patients and prohibiting access to care for patients. When we look at where this is already taking place, this is already done in some capacity in 13 states is what I would say to committee. We have a number of different subject matter experts. You heard from Roy, Ms. Linda, but also Dan Shackle can kind of lean in and say why this is so important. And I just ask for a favorable report for Senate Bill 699.
Good afternoon, Madam Chair and committee members. Thank you for this opportunity to speak in support of Senate Bill 699. I'm Dr. Linda Horn, and I've been a physical therapist for over 40 years, and I'm currently the Director for Government Relations for the American Physical Therapy Association. And while I'm a full-time faculty member in a DPT program, I am also still working with adults who are at high risk for falls or who have fallen. We're in the midst of a silver tsunami where 1 out of 6 adults in the United States over 65 fall every year, and that's according, or we have 1 out of 6 adults in the U.S. that are over 65, according to the census in 2020. 1 out of 4 of them fall every year, according to the CDC, and that may be low because they don't report it. And 112 adults die every day that are older adults as a result of a fall. Research studies have shown that many falls can be prevented, and the key is to keep moving. Many older adults need physical therapy to help them safely exercise. And physical therapists, we can determine which muscles are weak, we can assess their balance, decide the best exercises they can do, and also if they need an assisted device. It is better to evaluate and treat people before they fall, maybe in their 50s or 60s, or when they have chronic medical conditions. However, there are barriers to patients being able to attend physical therapy, and most of my career has been spent treating patients in Southwest Baltimore. They have shared with me that they're unable to come to therapy because of limited income, and they tell me they can only come to 2 to 3 visits, not a week, but total. In 2023, the American Physical Therapy Association released the economic value of physical therapy in the United States, and the average net cost savings for fall prevention is $2,144. If copays were lower, more patients would be able to access the physical therapy that they need. We chose the words annual physical or wellness visit because there was opposition to the word primary care visit previously in a previous bill. While physical therapy is considered a specialist by insurers, we should be in a separate category outside of the physician category as we are not physicians. We welcome the opportunity to discuss the actual copayment wording with the insurers. I respectfully ask that the committee gives a favorable report to Senate Bill 699.
Good afternoon, Madam Chair and members of the committee. I'm Dr. Roy Film. I'm an orthopedic physical therapist with 30 years of experience, and I used to own a private practice in Ellicott City. One of the things that I really love the most about being a PT is being able to help people avoid elective surgeries like joint replacements and spinal procedures. My patients were typically able to manage well enough with physical therapy and a supervised program that the surgeon would cancel their surgery, often saving tens of thousands of dollars per case. Not to mention being able to return to gainful employment and the cost savings to employers that this would also generate. There was a cost analysis study commissioned during the previous attempt at passing similar legislation 4 years ago. However, it did not include any cost avoidance analysis. So in other words, it was not really a cost-benefit analysis at all, and it assumed zero downstream savings. So that models a really unrealistic fictional scenario. Today, we have newer data. We have up-to-date data, including the study that Dr. Horn mentioned. But there was also a large multi-state outpatient PT claims-based analysis just published 5 months ago that showed that eliminating copays completely, even still, led to lower use of imaging, injection surgery, and physician services and lower overall costs. And we're not asking for nearly that much. The CDC and the World Health Organization both recommend non-drug therapies, including PT, as first-line treatment for acute and chronic low back pain. However, high PT copays really create an artificial systemic barrier that drives people away from care. These policies really foster more chronic pain, more surgeries, more injections, more opioid use, and overall more health inequity. And there's been no evidence of runaway utilization or cost shifting as the result of these policies. Thanks very much.
Thank you. Dan?
Okay. Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the American Physical Therapy Association Maryland chapter. So I want to go back in time a little bit. We were here in 2022 with this bill, and since that time, we've had a study by the Maryland Healthcare Commission, and we've also had the opportunity of these studies having been conducted. Also, 2 other states have passed legislation where now we have 13 total states, and you'll see I submitted with our testimony all the state statutes, but also a little cheat sheet to show that of those 13 states, 10 of them base their copays on the cost of a primary care visit or a physician's office visit. So what we're asking for is not anything really new that hasn't already been done in other states. Additionally, New York and Rhode Island are pursuing similar legislation this year. So of these states, which go back to 2012, I think was 2011 was when the first law was passed. No states have since gone back to redo what they passed. There has not been a calamity in the insurance market. There has not been runaway utilization. I think what we're trying to demonstrate is there's still a problem here in Maryland. The copays are prohibitive, and in Maryland you can access the services of a physical therapist without needing a referral. So oftentimes if you have a surgical procedure or heaven forbid you're recovering from a cardiac or stroke event, you're going to work with a physical therapist. But there's also times where, like for my plan, for instance, I could just access a physical therapist if I'm having shoulder pain or something and I don't want to go the surgical route. So when we run up against these high copays, it really does create a barrier to the preventive care that, as Dr. Film was saying, yields good benefits, yields savings to the overall healthcare system. So with that, we ask for your favorable report, and you'll hear some other examples from other members of our panel. Thank you.
Thank you, Dan. Senator Reedy has a question.
Thank you, Madam Chair. I'm curious about this because we always have bills that come in. I've had bills and I've opposed bills that are going to add a mandate or add different copay coverages. And we're going to hear from our friends that the insurance company folks that always are watching these things, and they should watch them. I mean, we have to balance things. Can you talk about how would this, the concern about overutilization is why we obviously have to limit, not everybody, you don't want people going and getting, x-rays every time their arm hurts, right? So I feel like physical therapy, just in my opinion, not based on any science, it seems like that's not something you're just going to rush and do because you're feeling a little discomfort. You're not going to go, hey, I want to go to my physical therapist. Can you, but for the concern about overutilization, can someone speak to that? Because, and then a second question, I'll ask them both now, and if it needs to be somebody different, is there a study from the Health Commission about the cost here? Because about how much it would add or the cost sharing? So go ahead, thank you.
So I'll take the second question first. So there was a study commissioned 4 years ago after the first attempt.
That's right. Okay.
And the fiscal note that we have now does show that it would increase, that it would be $3.6 million per year. That only looked at cost. It did not look at any cost avoidance. So That's what I was referencing in my comments, that it really
And this
wasn't a
would be
cost-benefit
consistent,
analysis.
this bill would be consistent with past efforts to incentivize low copay or for things that are preventative.
Yes.
I had a great bill that I still haven't been able to get through because it's not technically preventative. A lot of people agree it's a good idea, but it's not preventative, and then we've kind of kept it in the preventative standard, so this would be in the preventative standard. of that.
Absolutely.
Question is just of balance, and then I guess the next question is, what assurances, or is there some data we can see where this isn't going to cause overutilization?
So all the other states where this has been introduced, it hasn't led to increased costs. There's been no outcry from the insurers that it's costed them more, so they haven't tried to repeal anything in any of the states. So in general, this seems to have been successful, or at least not a negative impact to the insurance market at all. We completely recognize that it's very important to have a functioning insurance market. We absolutely don't want to overburden the insurance market. We see this as something that would actually be a real cost savings. And finally, this is something we've believed for years. And now in the last 4 years since the last attempt at bringing this bill forward, we have data to back that up. We just don't have specific data in Maryland because we don't have access to those databases to be able to see that. Each insurance company would have to look at that on their own. But our general perspective on this is that we can help save the system money. Physical therapy is very high value care at low cost. United Healthcare, specifically, one of their vice presidents that I've spoken with several years ago, they viewed physical therapy as one of their highest value expenditures. And a lot of the other things that are very commonly much more expensive, they consider to be much lower value care.
Okay, thank you very much.
Sure,
thank you, madam.
Thank you. And I love my physical therapist, but I have two questions. Dan, I don't have the MHCC report. What was the PMPM on this?
It was, I actually have like between 28 cents to 32 cents on the dollar.
Per member per month.
Per member per month. And that, so just going back to 2022, the fiscal note that initially came out was very large. It was inaccurately calculated, and that was corrected. But the number that was finalized was like around $8 million. And then the study basically came back and said, well, it might be a $3.6 million cost. And I think our fiscal note, if I recall, is like $1.8 million for this year. And that is looking at the cost to the state health benefit plan, which, we've often said before, they're not required to follow the mandates, but they often choose to, but they don't have to. The only exception to that now, and you'll probably hear from Kaiser, is Kaiser has a plan on the state market, and because they're a capitated plan, they have to follow the mandates. But we don't know what that number value would be. So, the numbers are going down. And to the utilization point, yeah, I think we just have, with the absence of that overutilization data, we just feel like things are working in these other states.
My other question is, the bill actually says that it can't be greater than the copayment, coinsurance, or deductible imposed for the annual physical or wellness visit. I think in Maryland, we don't pay for an annual wellness visit.
Right.
So it would be zero.
So that wasn't the intent, to have a zero.
Okay.
It was more trying to avoid, when the Healthcare Commission did the study, there were members of the commission that were primary care docs on the commission who were concerned that PTs might be trying to become primary care providers. We just were trying to link the cost of the copay to the primary care copay. We're not saying that they're primary care providers. So we were choosing different words, but as Dr. Horn said, we're happy to discuss the parameters. We weren't wanting a zero.
Okay. Yeah, that might need an amendment.
Yeah.
Okay, thank you. Senator Gao?
Thank you, Madam Chair. So Dan, I guess I just have one question I'm trying to understand. Copays are annoying, right? But there are a lot of providers. We have to pay a lot of different providers copays. What's the deal? Why are we accepting out physical therapists specifically?
Do you want me to, or?
Oh, well, anybody,
Okay,
I guess you can, whatever.
I think part of it is that we are different than when you go to a physician. It's usually one-time visit. When individuals go to physical therapy, sometimes it's 1 time a week, 2 times a week, 3 times a week for 4, 5, 6, 7, 8 weeks. And so they have these multiple copays coming out, and that's where that adds up and makes it very difficult for them to then get the level of care they need. Some individuals stop physical therapy early, and then they never reach those goals, which means that they're never then getting that cost savings that they could because they're not able to get enough physical therapy.
Okay, because it's something that you're going to consistently, maybe weekly or a couple times a week? Or
Yes,
could
yes,
be
more often than you would go to
a
your
greater
primary care
frequency.
physician.
Okay, all right, thank you. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions. Thank you very much. We are going to bring up the panel of unfavorables.
We have another favorable.
Do you? Give me a
Krista
second.
Frederick.
I've lost my place. Oh, Krista Frederick, okay. This was a little different the way we had the list, but thank you. Krista, go ahead.
Hi. Thank you. Thank you, Madam Chair, for the opportunity to testify in support of SB 699. My name is Krista Frederick. I'm a therapist with 20 years of experience, and I own a private practice with 11 locations in Central Maryland. We serve over 60,000 Maryland residents across 5 counties. I strongly agree with all of the testimony you've already heard, and have a couple of points to address that were previously brought up. Physical therapy utilization is not waste. If you've been a patient, you probably know patients often joke that PT stands for pain and torture. And while we try to make therapy a positive experience, the reality is nobody comes to PT casually or for convenience or because it's getting paid for. It's costly in time off of work, transportation, energy, and it actually requires real effort to get better. People accessing our services are people who are choosing to try to take ownership of their health and be proactive. And we need to make it easier as a healthcare system for people to do that and make that decision. My practice for years has had payment plans with 0 interest, and we've offered care credit opportunities for people to overcome these copay barriers. And I will tell you that people are unwilling, even with those opportunities, to come to physical therapy because of the barrier of the cost, particularly in some of our lower income areas. They come for one visit and they say, I can't do it. And they will go get opioid prescriptions for $10. They will go get orthopedic surgery for a $50 copay and then still need physical therapy afterwards, which they do not access, and they end up in chronic pain or with chronic disability. And also, Maryland has had direct access since 1979. We were the first state in the United States. We are primary care access for the last 50 years, and we need to allow people to actually be able to access us and remove the barriers for them to do that. So, thank you for your time.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield in respectful opposition to the bill. So it was helpful to hear the testimony of the panel before. I will tell you one of the things that stood out most about this bill is tying the copay to an annual physical, which, as one of you, I think, I wasn't looking up to catch whose voice it was, pointed out, is at 0 cost share, which would then turn this bill immediately into all physical therapy visits are 0 cost share, which is certainly how you got to a $3.6 million fiscal note for the state employees plan. As you know, the fiscal notes are emblematic of what would happen in the rest of the commercial market as costs would rise because of that cost shift in this particular case. I'm not clear, in the absence of tying it to the cost share, because the bill doesn't specify a cost share, what the bill is then trying to do. But what I would say is, my physical therapist is actually also one of my favorite people, Madam Chair. I personally see the value in physical therapy, as we do as a company. It is an important benefit to our members. As Senator Guile pointed out, outside of those mandated spaces where there are zero cost share for primary care visits, just about everything that we do does have a cost share. It is part of the economics of healthcare, and it is how we create balance, because otherwise, if we put all of the costs into the premium, it would be cost prohibitive. And so there is a reason why deductibles, cost share, and co-payments do exist. We are not in any way looking to have them be outsized for physical therapy, and certainly recognize, as you heard, about the slightly different pace of that care. Happy to continue talking to the proponents, because again, they did sort of shift from where the bill has been introduced. And like I said, I'm not exactly clear where it's going to head next. But as introduced, certainly with the zero cost share that this bill reflects, we urge your unfavorable report.
Me? Yeah. Okay. Madam Chair, members of the Senate Finance Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers opposed to this bill. We're opposed because, first and foremost, physical therapists are specialists. Treating a specialist like a primary care physician is inappropriate, and it undermines the reimbursement and cost-sharing structure and design to encourage primary care visits for preventive usage and healthcare outcomes. Because we know that primary care catches things early, it's better for outcomes and ultimately saving the healthcare system some dollars. Well visits are $0. Sick visits are generally very low. Primary care is designed to be baked into your premium to encourage healthy behavior. We also save a lot of money when we get people to go to primary care. Having physical therapists to be lumped in with this approach is inappropriate. The cost sharing is generally the same as any other specialist and should be treated like everyone else. Physical therapy is just not like going to your PCP once a year for a well visit. They are generally reoccurring and therefore require a different level of reimbursement, sort of the same way as like you would treat an oncologist. Once again, linking physical therapy to primary care, a primary care appointment is inappropriate. We can't start cherry picking specialists that want to reduce costs for sharing for beneficiaries. It has the potential to bring the entire system sort of crashing down. Lastly, I do want to point out to the MHCC study from 2002 on this bill. The commission said, quote, "In a high-functioning healthcare system, primary care providers are expected to provide patients with primary care comprehensiveness, first contact access, coordination, and continuity of care. Important as other services may be, they should not be given parity with primary care." We respectfully request an unfavorable report. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Neither Kaiser nor me personally dispute anything that the proponent said about the value of physical therapy. I did want to talk about one specific use case. As you all know, in the individual on-exchange market, carriers design plans at certain metal levels, and that is based on the what we call the actuarial value of the plan, or the amount that you would expect to pay for in out-of-pocket costs and other such things. So for us to maintain those benefits at that actuarial value level, we literally would have to raise the copay of something else in order to lower the copay on this. So not personal to the physical therapist, but there are plenty of really deserving healthcare specialties that that we want to make sure everyone is thinking about too.
Senator Reedy.
Sure. Maybe I'll ask, maybe Kimberly, maybe check with you on this. I guess I'm trying to understand, where do you all come in as insurers on incentivizing and removing barriers to preventative medicine? Do you generally, as a practice, oppose pretty much everything we've done on the mandate side? No, I'm not trying to be funny, because I think it's a fair. We just had the bill earlier today about how we can't possibly let people buy across state lines because they don't have all our mandates. And so, I mean, I get it, but I'm just trying to understand whether this is the right one to do it on or not. I think they make a good argument, but I also just help me understand where do we come down on trying to be sure we remove some barriers to sort of preventative maintenance or preventative care?
Sure. So me back up. So when it comes to how insurance is designed, we have a lot of levers that are getting pulled, right? We've got first and foremost what is being required at the federal level in a post-ACA world. The benefits that are being included, especially on the preventative side, are actually fairly prescribed for us. And so I think that's what Ms. Taylor was referring to, right, when she talked about even how they're priced and how we have to create the tiers and the metal levels are all built around that underpinning of what the ACA says. These are the benefits that are your core benefits in health insurance. In Maryland, we add on our mandates.
Well,
right?
just one second. I'm
Sure.
curious about that. On the ACA, so the ACA would not consider physical therapy.
It does not. It doesn't treat it as preventative care.
Okay.
It's
okay.
not, it doesn't fall
Continue.
under
I'm
that
sorry.
bucket.
Continue.
No, it's a good question, right? It doesn't fall in the preventative care bucket from an ACA perspective. We'd be having a different conversation if it did, because it would be treated a certain way if it was in the preventative care services under the ACA. And so starting with the federal level, and then we can at the state level, and this body does make decisions about what things are going to be mandated for coverage at the state level. We've been doing it for many, many years. And when you bump that up against what's happening at the federal level, we have to then balance all of the things that we talk to you all about. It's why the MHCC does the study, because with every additional mandated benefit, there's a mandated cost because you're guaranteeing that benefit is available under that policy. And so trying to find the right balance of what people need, exactly how they're going to access it, and then also trying to ensure that they can afford the product that's going to provide them that access is more than a notion. At the end of the day, I always say affordability is accessibility, because it doesn't matter what we put in an insurance policy if you can't afford to buy it, right? Yeah. And so the way that the cost sharing works, when we talk about deductibles, co-payments, co-insurance, all of those things are added into share in that cost ultimately and how that's being funded. Like your premium is doing part of that, and we all are paying that. And yes, we do end up still having to pay at the counter often for many of our doctor's visits or our labs or other things. There are some that are specifically excluded, so we do not pay for those, and they're picked intentionally to ensure that you get that set of services because they are often your primary care. They're the things that are most intended to, as Matt said, coordinate your care, and do our best to help keep you well in the first place. But we then treat all the specialists largely the same on the other side once we get to the more acute care. And physical therapy is a tremendous value in terms of that ability, as we talked about, keeping a condition from getting worse that leads you to more expensive care. And it's why it is covered, but it is covered with a copay because it does fall into the specialty bucket for a reason.
And is there no way to limit the copay without piercing the wall of what ACA says is preventative? Is there a direct nexus there, or is that just part of the calculation?
I would say I don't think it's typical for the state to attempt to actually codify specific dollar amounts for copays. I think it becomes challenging to keep that updated economically over time.
Yeah, I guess I'm not saying codify an exact amount. I'm trying to find a middle ground on the. Yeah. Sounds to me like that ACA may need some work done to it. I thought it was supposed to be affordable care, but it's kind of not necessarily been that way. Okay, thank you very much.
Thank you, Senator. I don't see any other questions. Thank you very much for your testimony. We have two virtuals, Rachel Rioli and Z Gamani. So who's up? Rachel? Will you unmute and give us your testimony, please?
Hi, yes. Good afternoon, Madam Chair, committee members. Thank you for the opportunity to speak in support of Senate Bill 699. My name is Rachel Rioli. I'm a physical therapist. I hold a PhD in rehabilitation science, and I'm a board-certified specialist in neurology. I also serve as the Vice President of the American Physical Therapy Association of Maryland, and I'm a full-time faculty member at the University of Maryland School of Medicine. As you just heard from Dr. Horn, our population is aging, and with that comes a growing number of falls. From a neurologic perspective, falls are not minor events. Individuals who fall are at higher risk for serious secondary injuries, including spinal cord injuries and traumatic brain injuries. These injuries can be life-altering for patients and incredibly costly to our healthcare system. These are not short-term problems. Often these injuries require surgery just to achieve medical stability, and they're often followed by months or longer of intensive rehabilitation. During that time, patients and their caregivers are frequently pulled away from work and daily responsibilities, adding to the financial and emotional strain. The cost adds up quickly, not just for families, but for our system as a whole. And the hard truth is that many of these injuries are preventable. Before I became a professor, I worked as a physical therapist for more than a decade. While working in the inpatient rehabilitation hospital, I treated a patient over 90 years old who sustained a cervical spinal cord injury from a fall. I remember this patient expressing deep regret that they had not followed up with their outpatient physical therapy to address their balance issues earlier. I think we can all think of older adults in our lives for whom even modest copays can make preventative care out of reach. Maryland would not be alone in taking this step. To date, 13 states have passed similar legislation to limit the cost of copays, recognizing that prevention is both compassionate and physically responsible. Thank you for your time, and I respectfully ask for a favorable report on Senate Bill 699.
Thank you, Rachel. Z?
Good afternoon, Madam Chair and members of the committee. My name is Zishan Bimani, and I've been a physical therapist for 11 years, working in different settings ranging from outpatient, skilled nursing, and home health. Currently, I work as a home health physical therapist in Montgomery County, and I'm also the director of reimbursement for APTA Maryland. I'm here to urge a favorable report for Senate Bill 699. Physical therapy is a cumulative process. We work in conjunction with the biological healing process, which requires multiple visits over time for it to be effective. Due to the current copay system, a $60 to $80 copay per visit cumulatively leads to an out-of-pocket barrier of approximately $600 per month for the patient. When the patient can't afford the dosage, they end up skipping visits or end up stopping treatment completely. For instance, I had a patient who came to our clinic with complaints of low back pain. He received a few sessions of therapy and then stopped abruptly, stating that his back pain was better and the high copays made it unaffordable for him to continue the recommended dosage. After a few months, the patient came back, mentioning that he had aggravated his back pain, for which he had to go to the emergency room, get imaging, and finally get a spinal injection, which helped him with pain for a few months, but the effects started wearing off. His orthopedic recommended him to continue managing the pain with physical therapy. All this could have been avoided if the patient would have continued the initial recommended dosage, and he would have had a better outcome. Studies show that PT management gives a net cost benefit of $4,160 for acute low back pain. This fair copay bill will not only help lowering the fee, but will also help patients choose a path which is replacing expensive surgeries and injections with proven conservative care. Thank you.
Thank you. Do I have any questions for these two witnesses? No questions. Thank you very much. That ends the hearing on Senate Bill 699, and now we're going to hear Senator Mounts. Let's start with Senate Bill 608, Senator. This was a prior introduction, so we'll have two proponents. And we don't have any opponents. Okay. Thank you, Senator.
Thank you, Madam Chair, Mr. Vice Chair. Would it be okay to bring my, we have we actually only have one.
Paul Sheaves?
Yes. Mr. Sheaves. Shives. I got to apologize on the record for butchering Mr. Shives' name all day long. I've done it like 3 or 4 different ways. I'm very sorry. I
At least
apologize.
you're paying attention. It looks like Sheaves.
Madam Chair, Mr. Vice Chair, distinguished members, it's an honor to present Senate Bill 608, which aims to mandate that the Maryland Medical Assistance Program and various insurers provide coverage for a single gene and multi-gene pharmacogenomic testing when ordered for treatment of depression or anxiety. Pharmacogenetic testing is a laboratory analysis of your DNA via saliva or blood to determine how specific genes affect your body's response to medication. It helps doctors select the right drug and dosage, reducing side effects and improving effectiveness, particularly in psychiatry, cardiology, and oncology. Pharmacogenetic testing is highly accurate at identifying specific genetic variations that affect drug metabolism. It acts as a guide to reduce trial and error, improving medication selection and minimizing side effects, which can help in achieving faster resolution for a patient's issues. This bill should be familiar. We brought this bill last year. We had a favorable report by the Healthcare Cost Commission. In the beginning of my testimony, I intimate that this is mandates. Well, it really doesn't mandate. It does in that fact we have it in this bill, but the assertion here is that this should have already been covered by legislation that's been approved and enacted by this committee. Subsequently, it was determined that it wasn't covered, which is why we're coming back now to bring this legislation. So with that being said, I just would also, remind the committee, I know we only have a handful of members, but we brought this bill last year and had a discussion. And the question was, how many times had it been approved in Maryland? And the answer was never. It had not been approved. Now, you may want to correct that for me, but I just wanted to kind of refresh everyone's memory from our testimony because we had a really good hearing last year. So with that, I humbly request for the committee's favorable report. Thank you.
Thank you. And Mr. Shives?
Hi, my name is Paul Shives. I'm Vice President of Government Affairs for Myriad Genetics, for one of the oldest personalized medicine laboratories in the country. Thanks for the opportunity for testimony today. I think this legislation will ensure equitable access to critical pharmacogenomic testing for mental health. Today, Maryland is grappling with rising levels of mental illness worsened by a shortage of mental health providers and facilities. It's particularly the case in rural and underserved communities. Mental health care providers urgently need tools and solutions to address this crisis. Medication is the most common form of treatment for depression, but only a little more than a third actually reach remission on their first medication. It's important to get these patients to the right drug. This testing basically looks like, are you a hypermetabolizer of the drug? If you are, you're never going to have enough in your system. And so all of these different drugs that are used to treat mental health, won't work unless dosage adjustments are made. Or you may be a hypometabolizer and it's building up in your bloodstream and causing adverse events. And that has a high correlation to adherence to sticking to these drugs, or whether or not they're going to work for you at all. There's been a lot of clinical studies specifically on our test. We have a meta-analysis that looks at pooled remission rates and shows that if you use this test in the normal course of treatment, you're going to see about a 41% increase in the likelihood of achieving remission, and also a decrease in the time to remission. That's the type of data that was verified in a nearly 2,000 patient study. It was independently done by the VA. We had nothing to do with it, just used our test. And there's data that says this saves money. So there's a citation here in my written testimony that we could save up to $3,400 per patient compared to treatment as usual. And again, this does things like decrease polypharmacy costs, a decrease hospital admissions, a decrease ER visits, cost to the state. Think about getting people back to work, interactions with law enforcement, many things you see with people in mental health crisis. And you also see kind of control on comorbidities as well. So, this isn't a bill that says let's cover everything. It says let's cover mental health pharmacogenomic testing for just if it's covered by Medicare, which it has been for 10 years.
Hi, I have some questions, Mr. Shives.
Sure.
So it's currently covered by Medicare, not by Medicaid, but by Medicare?
By Medicare for the last 10 years.
And is it a blood test?
It's a saliva test.
Saliva test? What does it usually cost?
The Medicare fee schedule rate is around $1,300. If you looked at like what it would be in Medicaid, you're talking about probably $1,060. It's a once in a lifetime type test, though. This isn't. You have to go back and switch medications again and again. However, the treating physician is managing the patients, it's a one-time cost.
So it helps the doctor know what medication to prescribe.
So the doctor will use their own clinical acumen to say, hey, I like to use this drug. But if you have a gene that says you're not going to metabolize that drug, it's never going to work. So I can do this test, whether it be at the first visit and the first medication, or you're failing one, and it'll get you
How
on the
often
right
does
drug.
it happen that the doctor recommends a certain medication based on that blood test and the insurance company refuses to pay for that medication?
I don't have data on that. I don't think the problem's with the coverage of the medication typically, though. It's just that you're kind of doing trial and error, right? Hoping that you're getting one that's metabolized right.
Well, I just asked because so often we have to take generic medications.
Yeah.
So I was just wondering if the insurance companies really follow that recommendation, or they try to put a generic in.
We don't see it on I don't have access to the back end of, what's being covered and not. It's really just, we know when we have our test used, the report's issued, how they manage a patient that you see these improvement of patient outcomes.
Thank you. Do I have any other questions? I don't see any other questions. Thank you very much. That ends the hearing on 608. Senator Mouse, you're going to do Senate Bill 910, health insurance graduate level clinical interns, and you have Beth Ann Dorman and Jeannie Hadaway-Riccio.
More good news for the committee, Madam Chair. We have slimmed down our proponent panel.
Okay.
But we brought out the big guns. My delegate, my secretary, my constituent, and also my neighbor. But before I do that introduction, I better introduce the bill. Madam Chair, Mr. Vice Chair, committee members, it's an honor to present Senate Bill 910 as amended. Senate Bill 910 would make clinical services provided by supervised students reimbursable by insurance. Currently, the services of master-level interns providing in-person services within an outpatient mental health clinic under the supervision of a licensed provider are covered under insurance. Once placement of the intern changes through their local school program, for instance, when the semester ends, their services within the clinic setting are no longer covered under private or commercial insurance plans, nor Medicaid. Due to the loss of billable insurance coverage, the client is often disconnected from continued services with the intern they had become familiar and comfortable with. We all know the need for additional mental health services. This bill will expand access for those services. I appreciate your consideration and respectfully ask for a favorable report on Senate Bill 910 and would like to turn the microphone over to our expert witness testimony.
I don't know about expert, but I appreciate the opportunity to be here. So good afternoon, Madam Chair and members of the committee. For the record, Jeannie Hadaway-Riccio, I'm here on behalf of For All Seasons. For All Seasons is a licensed behavioral health and rape crisis center that has served the state of Maryland for 40 years, and we utilize these types of services. So we would like to thank the senator for introducing this bill. As he indicated, this would allow graduate level counseling, social work, and psychology clinical interns to provide billable services under a very narrow set of circumstances, including the fact that those services are provided under the direct supervision of a licensed clinical professional counselor. And we believe that passage of this legislation will assist with continuity of care. As the senator indicated, it will also enhance access to care. But I know that this committee hears often about workforce shortages, and we see this as a great professional development tool for interns that are working at this master level. And so with that, we appreciate the opportunity to be here and ask the committee for a favorable report.
Thank you. I don't see any questions. It's nice to see you, Jeannie.
Thank you.
Next, we're going to have Carissa Proctor.
Thank you.
And Michael Patty, why don't you come up too? I know you're favored with amendment, but we'll get you both here on the table. Thank you.
Good afternoon, Chair and members of the Senate Finance Committee. My name is Carissa Proctor. I am the Executive Director of the National Association of Social Workers Maryland chapter, here representing over 2,600 social workers today. As they've said before, this is a workforce bill. It is an access to care bill. It is a common sense modernization of how we recognize behavioral health services already being delivered across Maryland. Graduate level clinical interns for social work, counseling, psychology complete hundreds and often thousands of hours of supervised clinical training in hospitals and other settings. These are real services delivered to real Marylanders and facing real behavioral health needs. And while this bill does not pay interns directly, it ensures that when supervised interns provide services as part of an accredited graduate program, those services are eligible for reimbursement under health insurance policies. It also strengthens the educational value of these clinical degrees. And as you all might be aware, the federal government is attacking our professional degrees. And we believe that this will strengthen the value of our clinical degrees. It is where theory meets practice. When insurers recognize services delivered in these structured, supervised settings, they affirm the rigor and legitimacy of graduate level training. And Maryland should not penalize agencies for training the next generation of behavioral health providers. It acknowledges what we already know is true. Supervised graduate interns are part of Maryland's behavioral health continuum. Their services improve access, strengthen communities, and contribute to public health outcomes. So for these reasons, the NASW Maryland chapter respectfully urges a favorable report on Senate Bill 910. Thank you for your leadership.
Thank you. And Michael, you want to do your favorable with amendment?
Yep. Michael Patty here today on behalf of the Maryland Community Health System, a network of 7 federally qualified health centers across the state of Maryland with 55 care delivery sites. FQHCs provide somatic behavioral health and dental care to underserved communities. And I want to thank the senator for working with us and hopefully viewing these 2 amendments as friendly amendments. The first amendment is pretty straightforward. It just adds a few words to clarify that a outpatient healthcare facility can include a federally qualified health center. And then the second amendment, while it looks like a lot of language, it just does the same thing as the other 3 parts of the bill. It includes that marriage and family therapists, clinical students also fall under the same scheme that's established for counseling interns, social work interns, and psychology interns. So with that, we'd ask those amendments be adopted and for a favorable report. Thanks, Senator.
Thank you. So you were working with the sponsor on the amendments.
Yep, I had a great conversation with Ms. Hadaway this morning and with Senator Motz.
Thank you. Do I have any questions for this panel? Seeing none, thank you very much. I think we have 2 virtuals. Let's start with Jordan Anderson. Jordan, can you unmute and give us your testimony, please?
Hi, good afternoon to Madam Chair and the members of the Senate Finance Committee. My name is Jordan Anderson. I am a social worker in higher education, where my primary responsibility is to secure internship placements for graduate level social work students across the state of Maryland. And in nearly every placement interview that I have conducted, students share their aspirations to work with individuals navigating one or more mental health diagnoses and want to provide treatment modalities to children, youth, and families to improve how they function as community members. And almost immediately after making placement recommendations and restating the requirements from our accrediting body, they explain that they cannot afford to stop working in order to obtain their financial goals. Our accrediting body mandates that students accrue a number of internship hours similar to what Ms. Proctor just shared. And students must meet those requirements in order to get a degree. And so many of the cases, students are interning, going to work full-time, part-time, and even supporting their families. And this strain shows up in their programs, their educational programs, with financial instability, academic disruption, emotional exhaustion, to obtain a degree that strengthens how individuals improve in our Maryland communities. I share this not only as a social work administrator, but from lived experience. While completing my second year MSW internship, 24 hours per week at an outpatient mental health clinic housed in an elementary middle school, I provided clinical services to students. I provided clinical services to insured clients without compensation or reimbursement under the supervision of a licensed clinical certified social worker clinical. I was also working 2 part-time jobs and attending graduate school full-time. And so if this legislation had been proposed and passed prior to 2018, I personally could have benefited from this, as well as continued the continuity of care. Unfortunately, for years, the burden has been normalized for social work students while the cost continues to rise. And so I respectfully urge for a favorable report on Senate Bill 910. Thank you for your time.
Thank you, Jordan. Now we'll hear from Elizabeth.
Hi, my name is Elizabeth Guroff. I am representing the Board of Professional Counselors and Therapists. I sit on the board as a licensed clinical marriage and family therapist. And as a board, we support the proposed legislation, but with amendments. We think that it is a very important bill to support our interns, but we want to make sure that it is not just discipline specific, but open to all interns on the master's level, counselors and therapists. And so we're actually asking for an amendment that would open this up to all disciplines that are regulated under Title 17 of the Health Occupations article. So it wouldn't just be professional counselors, social workers, and psychologists, but would also include marriage and family therapists, drug and alcohol counselors, and professional art therapists.
Thank you for your testimony. Are there any questions? Senator Mounts.
Mrs. Garuff, is that the proper way to enunciate Garuff?
Yes. Yes.
Okay. I'm sorry, I've been having a rough day with names.
It's all good.
That's a personal thing. We don't need to bring that into the hearing. Thank you for bringing that suggestion. And I was interested to know if you would possibly be willing to have a conversation outside of the hearing to talk about that amendment you're proposing. We can go over, the implications of what that would do, and then kind of move forward in the best possible way to make sure that it doesn't complicate the legislation. I'd be happy to work with you on that if you'd be willing to do that.
Absolutely.
Okay. Thank you very much.
Yeah.
Thank you, Senator. That ends the hearing on Senate Bill 910. Now we have Becca Rhodes here to present Senate Bill 551 for Senator Charles.
Hello. We do have a few people testifying virtually that are on the sponsor panel as well.
Give me a second. We're bouncing all over the place today, and here, I got it, page 2. Okay, so you have Aaron Wright, Eileen O'Neill. No, they're virtual. They're all virtual.
Yes.
So you want them all brought up to be part of the panel?
Yeah.
Okay, good.
If that's okay.
I think everybody's here.
Awesome.
Okay, so Becca.
Cool. Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, I am Becca Rhodes, Chief of Staff to Senator Nick Charles, and I am testifying in strong support for Senate Bill 551 on his behalf. At its core, Senate Bill 551 is about prevention, equity, and responsible healthcare policy. It expands access to a proven cancer prevention strategy while having only a minimal impact on insurance premiums. Senate Bill 551 requires health insurance plans in Maryland to cover salpingectomy for ovarian cancer prevention and ensures that women are not subject to costs associated with accessing this preventative, life-saving care. For clarity, a salpingectomy is the surgical removal of the fallopian tubes. Senator Charles first introduced legislation on this issue last year. At that time, the committee raised an important concern. The bill did not yet have a Maryland Healthcare Commission cost study to evaluate its financial impact. Since then, we have worked with the commission to address that gap, and today that analysis is in place. That study found the impact to premiums would be extremely small, measured in only a few cents per member per month. In other words, the financial impact is measured in pennies, while the potential benefit is measured in the lives of women across our state. We are grateful to once again be working with the physicians and medical experts who helped to bring this issue forward last year. They will speak in much greater detail about the procedure itself and the science behind it. But what I want to focus on today is the problem this policy addresses. Ovarian cancer remains one of the most lethal cancers affecting women. More than 20,000 women in the United States are diagnosed each year, and over 12,000 die from the disease. 270 women in Maryland will be diagnosed this year, with 69% of those cases being in the advanced stage. The reason outcomes are so poor is simple. As many of you may remember from last year's discussion, we do not currently have an effective screening test. Nearly half of cases are diagnosed only after the cancer has reached an advanced stage. Over the past decade, research has significantly changed our understanding of where many ovarian cancers begin. Scientists now know that many of the most aggressive forms actually originate in the fallopian tubes. That discovery has opened the door to this, one of the most promising cancer prevention strategies we have today. A large population-based study in Canada followed more than 25,000 women who underwent opportunistic salpingectomy and observed no cases of ovarian cancer among those patients during the study period. I will defer to Dr. Stone to speak more about the clinical significance of those findings and the broader body of research supporting this prevention strategy. What is important to recognize is that this is not experimental medicine. Physicians are already performing this procedure during appropriate surgeries in clinical practice. The reason we have such strong evidence is because the medical community has been studying its outcomes for years. But access to this preventative option is not equal. Evidence consistently shows that income, insurance coverage, and race play a significant role in determining who receives preventative care. Women with higher incomes, private insurance, and greater access to specialty care are far more likely to receive advanced preventive interventions. Women from lower income communities and women of color are more likely to face barriers to those same services and are more likely to be diagnosed with cancer at later stages. Insurance coverage plays a major role in addressing that disparity. When a preventative service is clearly covered, it becomes part of the conversation between physicians and patients. When it's not, many patients never even learn that that option exists. By including salpingectomy for ovarian cancer prevention in insurance coverage, this bill does more than remove a cost barrier. It increases awareness, it expands access, and it helps ensure that preventative care is available to all women, not only those with the resources to navigate the healthcare system. There is also a clear economic argument. Treating advanced ovarian cancer is extraordinarily expensive. Surgery, chemotherapy, hospitalizations, and long-term follow-up care can cost hundreds of thousands of dollars for a single patient. Preventing even a small number of cases can save millions of dollars in healthcare spending while sparing families from devastating diagnoses. Our healthcare system and this committee recognizes the value of prevention. Colonoscopies are covered because they prevent cancer, and prostate cancer screening is covered to protect men through early detection. When we have a proven opportunity to meaningfully reduce cancer risk for women, we should treat that opportunity with the same level of commitment. Senate Bill 551 supports prevention, it aligns insurance coverage with modern medical understanding, it expands access to a preventative strategy that physicians are already performing successfully, and it does so while potentially saving lives and reducing long-term healthcare costs. With me today is an incredible panel of women and experts who can speak directly to the clinical and patient impact of this policy. We have Dr. Rebecca Stone, Associate Professor and Division Director of Gynecologic Oncology at Johns Hopkins University School of Medicine. We have Pamela Johnson, Vice President of Care Transformation at Johns Hopkins, Eileen O'Neill, who will share a powerful patient perspective, and Erin Wright, representing the Maryland affiliate of the American College of Nurse Midwives. Thank you, and we respectfully urge a favorable report on Senate Bill 551.
Thank you. You did an excellent job. Thank you very much. Should I start with Eileen O'Neill? She was the first one you mentioned.
Can we start with Dr. Stone, please?
Dr. Stone, okay.
Thank you so much.
Dr. Stone, you want to unmute and give us your
Thank
testimony,
you.
please?
Yes, good afternoon, Chair Beidel, Vice Chair Hayes, and Senate Finance Committee. You may know ovarian cancer is a silent killer. The moniker is fitting because most women who develop it do not have risk factors or even symptoms. For decades, billions have been invested in developing a screening test, and yet we still do not have one that works. So ovarian cancer, as Becca mentioned, is typically diagnosed in an advanced, incurable stage when even the most cutting-edge therapies only extend life a few months. The average cost of care for one woman exceeds $1 million, and in Maryland, a woman is diagnosed nearly every single day. Finally, a scientific breakthrough has given us a decisive advantage over the silent killer. We now know that the most common and deadly forms do not actually begin in the ovary, but rather in the adjacent fallopian tube. And this discovery changes everything because population-level prevention is now possible. Removing the fallopian tubes, called salpingectomy, can cut the risk of ovarian cancer by nearly 80% for all women, regardless of genetic markers and other risk factors. It does not cause menopause because it does not remove the ovaries. Since salpingectomy offers the dual benefit of permanent birth control and cancer prevention, it is now the standard of care alternative to tubal ligation, and it's already standard at hysterectomy. It can be safely incorporated into other post-reproductive abdominal surgeries, adding only minutes and minimal cost. But prevention only works for people who can access it. If we act, Maryland can lead the nation in aligning policy with ACOG recommendations, a new ICD-10 coding from the CDC and CHS that recognizes salpingectomy as preventive care for all women. This is not just about a procedure. It's about replacing late-stage $1 million care with a simple life-saving intervention that stops ovarian cancer where it begins. for less than what we routinely spend on mammograms, colonoscopies, or even an airplane ticket. Thank you for your consideration of Senate Bill 551 and to Senator Charles for his leadership.
Thank you, Dr. Stone. Let's go to Aaron Wright, American College of Nurse Midwives. Aaron, you need to unmute.
I do this all day. You'd think I'd have it. Good afternoon to our chair, our vice chair, and members of the committee. My name is Dr. Erin Wright. I'm a doctorally trained certified nurse midwife and assistant professor at Johns Hopkins School of Nursing. But I speak to you today as a high-grade serous stage 3C ovarian cancer survivor. I represent the Maryland affiliate of the American College of Nurse Midwives, as well as the Ovarian Cancer Research Alliance with this testimony. And I strongly support SB 551, which requires insurers cover salpingectomy for ovarian cancer prevention without copayments, coinsurance, or deductibles. Ovarian cancer is the most lethal of the gynecologic cancers and is often referred to as a silent killer because symptoms like back pain, heartburn, early illness are easily missed. Approximately 30% of people diagnosed at my stage survive 5 years. I will reach my 5-year mark in 49 days, but nearly 70% of my peers will not. About 20,000 women in the US are diagnosed each year, one each day in Maryland, but salpingectomy removal of the fallopian tubes can reduce the ovarian cancer risk by up to 80%. Yet cost often deters women from choosing this preventive option. This bill removes financial barriers so women, especially those in marginalized communities, can make medical decisions based on need, not ability to pay. Supporting this bill is an investment in prevention, equity, and patients' lives. Please join me in supporting Senate Bill 551 to give patients and their oncologists the tools to transform risk into resilience. Thank you.
Thank you. Good luck. Waiting for your test results to come back. Eileen O'Neill.
Good afternoon, Chair Bidell, Vice Chair Hayes, and members of the Finance Committee. I'm Eileen O'Neill, here to testify in support of Senate Bill 551. I'd like to thank Senator Charles for his leadership on this life-saving legislation. I'm a longtime Maryland resident and the former group president of Discovery Channel and TLC cable networks. Like millions of women, I thought the annual GYN exam was able to take care of any and all gynecologic concerns, but as you've heard, not everything has a screening test. And 3 years ago, I didn't know anyone with ovarian cancer until my wife got diagnosed. It's been an incredibly difficult time for my wife. This is a horrible disease which requires significant surgeries and chemo to extend a quality of life worth living. I was told ovarian cancer doesn't just happen to the woman, it happens to the family. My wife, our son, and I would not wish this disease on anyone. During my wife's first year of treatment, I learned most women are diagnosed with advanced disease because there is no screening, and more devastating, there is no cure. So when I heard you could prevent this brutal disease with a minor procedure, I said, sign me up. I learned about salpingectomy, and equally important, I learned how to pronounce it. My path to a salpingectomy included genetic testing, which revealed I had a higher risk of getting ovarian cancer, making getting salpingectomy a no-brainer. Here's the real kicker. Post-surgical pathology revealed a precancerous lesion in my left fallopian tube. I was a ticking time bomb for ovarian cancer. Think about that. If I had not had a salpingectomy, there was the enormous chance I would have had ovarian cancer by the time I turned 65. Every woman in Maryland deserves the right to prevent this disease for herself and protect themselves and their families from the physical, emotional, and financial cost it inflicts. Salpingectomy saved my life. Please help save others. Thank you.
Thank you for that testimony. And Dr. Johnson?
Good afternoon, Chair Bidell, Vice Chair Hayes, and members of the Finance Committee. I'm Pamela Johnson, and I'm here to testify in support of Senate Bill 551. Thank you to Senator Charles for his leadership on this issue. I previously served as the Vice President of Care Transformation for the Johns Hopkins Health System, where I was also a professor of radiology with a joint appointment in oncology. Over the past decade, I have led efforts to redesign care at Johns Hopkins across all specialties and settings to improve patient outcomes while reducing costs. At the end of my tenure, I concluded that prevention and early detection are the most effective tools in our high-value care toolkit. However, these opportunities remain underutilized in the United States, especially for the two leading causes of adult death, cardiovascular disease and cancer. In oncology, evidence-based screening for lung cancer, breast, and colorectal cancer has significantly improved outcomes and protected patients from prolonged costly treatments that may extend disease-free survival but do not necessarily offer a cure. Ovarian cancer, however, remains resistant to effective screening, and as a result, many women are diagnosed at a late stage. For ovarian cancer, we have a unique opportunity to leverage an existing medically indicated surgical procedure to prevent this deadly disease, but access barriers must be addressed through coordinated implementation. Dr. Stone is leading an international campaign to eliminate these barriers, and the state of Maryland has the opportunity to set a national example and forge the path to eradicating this disease. Thank you very much.
Thank you for your testimony. Do I have any questions for any of these witnesses? Seeing none, that ends the hearing on Senate Bill 551. Thank you all very much for your testimony.
Thank you.
Thank you. Now we're going to hear Senate Bill 808, and Chief of Staff Patty Horton's going to present for Senator King. And I think you have Sally Ann Alburn, Howard Haft, Robin Elliott, and Dana Kaufman as your panel.
Thank you, Madam Chair, members of the committee. Patty Horton on behalf of Senator King. Last year, Senator King attended a meeting in the Montgomery County Medical Society and learned about the magnitude of the credentialing issues facing providers. Providers in federally qualified health centers are waiting months and have to jump through multiple hoops to be accepted on a provider panel. Meanwhile, Senator King is also hearing from constituents that there are not enough primary care providers, specialists, behavioral health providers, and dentists in their insurance companies' network. Our current credentialing statute dates back to the 1990s and was designed when credentialing was a paper process. Senate Bill 808 seeks to modernize our credentialing law by acknowledging the credentialing process can be and should be managed electronically. Senate Bill 808 updates Maryland law by reducing the credentialing timeframe from a maximum of 120 days to 30 days for carriers to process a completed application, ensuring payers are responsive to providers' inquiries about their credentialing applications, requiring all carriers to utilize a uniform electronic credentialing platform as designated by the insurance commissioner, requiring that platform to form an ongoing work group with providers and carriers to resolve operational issues, and providing the insurance commissioner with the authority to leverage up to a $500 daily penalty for a violation of the credentialing statute. Senate Bill 808 also contains provisions to improve the accuracy of provider directories for commercial carriers. Credentialing should be and can be streamlined, fast, and efficient. Senate Bill 808 will support healthcare providers in meeting the needs of their communities and improve healthcare access throughout the state. While we cannot increase the number of healthcare providers overnight, we can do better in ensuring that outdated administrative processes do not stand in the way of the provision of healthcare services. And so on behalf of Senator King, I respectfully request a favorable report on Senate Bill 808. Thank you.
Yeah. Thank you, Madam Chair Bidle, Vice Chair, and Senators. It's my great privilege to be here to speak in support of Senate Bill 808. I'm Dr. Howard Haft. I'm a primary care internist serving in Somerset County in Somerset Primary Care. I support this bill because it really modernizes a statute that has grown very cold and old in terms of its ability to allow 150 days for insurers to bring on a new provider to their network. I give you testimony based on my experience. I was very pleased after 52 years of practice to be able to start a new practice in one of the most medically underserved areas in the southern eastern shore of Maryland exactly 1 year ago. It's taken this full year to get fully credentialed with all of the insurers. 150 days plus some additional time for some of them to go through the additional signing of their contracts on their side. Obviously, this is an enormous economic burden and impossibility, in fact, to establish new practices or bring on new providers in medically underserved areas. This is occurring at a time when we have a desperate lack of primary care providers in rural areas and in many other medically underserved areas around the state. It's an issue that is also an economic issue. If we can't start new practices, we won't be able to have that kind of economic boom that's necessary that goes along with having good access to care, health care. And it also spans not only primary care providers and not only rural providers, but this affects all providers. Any new provider coming on in the state is faced with this up to 150 days or longer in order to get credentialed and not have any ability to gain any income during that time, no payments from insurers. I would say lastly that it's not because insurers are unable. One of the larger insurers in the state was able to bring me on and credential my practice within 30 days. So it is a reasonable approach to be able to shorten that time frame considerably. I urge a positive report.
Thank you. Dana?
Chair Beidel, Vice Chair Hayes, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of MedChi in support of this bill. When we say modernize, just so you understand, this statute hasn't been updated in almost 30 years. So systems have come a long way, but the statute has not. And why this is important is really what Dr. Haft was referring to. Until we get credentialed or the practices get credentialed, we can't see patients, which is why when we already have a shortage of practitioners and you're calling and you're waiting 6 months to get an appointment, it's why. It's also why Maryland in the between 2018 and 2023 saw a decrease in its independent physician practices of 45.9%, according to the Maryland Healthcare Commission. So it is extremely vital that we pass this bill to modernize this system. We think that the 30-day time frame, as Dr. Haft stated, is reasonable, given the electronic improvements that have occurred. And we also, there's another portion of the bill that we borrowed over from the prior auth, just on being able to contact the insurers to be able to find out information about your application. So for those reasons, we do urge a favorable report. We think the bill is needed. We think it's reasonable. We've got to increase our pipeline of practitioners. Thank you.
Good afternoon. Robin Elliott here on behalf of the Maryland Community Health System, very much in partnership with MedChi. We found out that we were both thinking about the same bill, so we teamed up, so you get one bill instead of two. And we're very excited because we know there's not any additional resources in the state for medical practices, for safety net providers, but we can do something to alleviate their administrative burden, which is significant, as you will hear from Sally Ann to my right and some of the panelists behind me. I just wanted to note, we know that there is a fiscal note that is created by a provision in the bill which has the MIA collecting a penalty and then remitting it to the providers. We've already had discussions about how to fix that to get rid of the fiscal note. We look forward to working with both sponsors and the committees on this very important piece of legislation. Thank you.
Thanks, Robin. Good afternoon, Chair Beidel and members of the committee. I'm Sally Alborn, and I'm the CEO of Maryland Community Health System. Maryland Community Health System strongly supports Senate Bill 808. MCHS is a network of 7 federally qualified health centers that provide a comprehensive array of primary care services at our 55 locations throughout the state of Maryland. Senate Bill 808, if passed, will modernize, as Dana said, and streamline an outdated and unnecessarily complex credentialing system. MCHS's written testimony outlines the multiple factors that contribute to credentialing being an administrative burden, consuming thousands of hours of staff time and costing providers hundreds of thousands of dollars in lost revenue, precious dollars that could be redirected to underwriting the millions of dollars in uncompensated care FQHCs provide to Maryland's 407,000 uninsured people, a situation that will only get worse when work requirements are implemented in October and the semi-annual eligibility redetermination begins in 2027. Just imagine the time and resources FQHCs alone expend credentialing our 861 providers in our network, credentialing them initially and then every 2 to 3 years thereafter. For these reasons and many others, I strongly support and ask for a favorable report on Senate Bill 808.
Thank you. We have a question from Senator Mounts.
Thank you, Madam Chair, and I'll try to be pretty quick because this is not a new issue. I mean, I've heard about it so much, especially you mentioned the Eastern Shore. I know practices we've actually lost, and they've actually changed. It's affected things, but I'm not sure who's the lead on the panel promoting the bill. Would that be Dana?
I think it depends on your question.
Okay.
You can answer it.
If you look at the opposition testimony, you go from, was it 160 days to 30 days, some of the penalties, things like that. Is there room for negotiation? Because I guess if you were to cut it in half, say not cut it 75%, maybe cut it in half and do different things, is there flexibility? Would you consider that success to make some changes, but maybe not everything that's in the bill?
We have started conversations with the insurers. We know that they are concerned about the 30 days, and some of the other timeframes are on the table, like 60. So we are definitely willing to continue to talk to get this bill to a place that we can pass this session.
That's good to hear. I hope you can get to a place because it is a real, present, serious, ongoing problem. I'll hear about it. If I go to a doctor event with doctors and I bring this up, look out, But so thank you for bringing the bill and thank you for being open-minded. If you can get this to get some improvements, that would be a fantastic thing. Thank you.
Thank you all. I don't see any other questions. We're going to bring up some more panelists. Dan Doherty, Tammy Osborne, Aaron Hansen, and Aaron Dorian.
Thank you, Madam Chair, members of the committee. I'm Dan Doherty here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons in strong support of Senate Bill 808. I think you've heard a good discussion of the problems that providers are confronting when it comes to becoming accepted for provider panels, the timeframes, the delays, and the impact on practices. So I'm not going to repeat that. I just want to reemphasize that this applies across the board to most healthcare providers, certainly to dentists, oral surgeons, and physicians. So with that, I would urge a favorable report. But in response to Senator Mount's question, we also are willing to discuss reasonable accommodations to try and get the bill passed.
Who's next?
Good afternoon. My name is Erin Allen Hansen, and I'm the Director of Programs at Maryland Dental Action Coalition, a statewide network of individuals and organizations working collectively to improve oral health of all Marylanders. Thank you for the opportunity to be here today to provide testimony and support of Senate Bill 808. The bill streamlines the credentialing process for all types of insurers, including commercial dental insurance. The coalition strongly supports the bill because 61% of Marylanders have dental coverage through commercial insurance, and we want to take every step to ease the enrollment of dental providers into commercial networks in an efficient and timely manner to facilitate and improve access to care. Senate Bill 808 will do this by streamlining enrollment in commercial plans through an online credentialing platform that shares applications from providers to insurers. This will reduce the current administrative burden on providers for credentialing, thus allowing them to redirect more resources and time to patient care. SB 808 will also move dentists into networks at a quicker pace. The current law allows dental insurers to take up to 120 days to process a completed credentialing application. This time frame is decades old and centered on a paper-based process. The bill recognizes that applications can be processed more quickly with today's technology, thus reducing the time frame to process an application to 30 days. This will allow dentists to move into commercial networks at a much quicker pace and further expand dental care for many Marylanders. Thank you for your time, and Maryland Dental Action Coalition respectfully asks for a favorable report.
Thank you, and then one more.
Good afternoon. My name is Tammy Osborne. I'm the credentialing specialist for a federally qualified health center, Choptank Community Health System. And if this bill would pass, it would improve the enrollment and approval process. First, by shortening the 120-day processing time to 30 days to see patients sooner. Second, it would improve the application process and forms by requiring the CAQH application be the only one used and eliminate additional and redundant forms. It would improve payer notifications and communications for submitted applications and their status. It would require dental providers to access applications directly from CAQH, eliminating the need to email or fax applications, compromising the security of personal provider information. It would allow dental providers to access CAQH directly, not through their ADA login. Third would be communication. There is a need to have timely responses from assigned, dedicated, and knowledgeable payer reps for application follow-up and questions. And some examples of application approval times: 133 days, 154 days, one submitted on August 7th of 25, and I'm still waiting for the approval. If passed, this bill will reduce approval times, improve access to patient care, and promote timely reimbursement. Thank you for the opportunity to testify.
Senator Lamb has a question.
Yeah, thank you, Madam Chair. To Ms. Osborne, I guess you're with the Community Health Center, FQHC, right? This
Yes.
is Choptank Community Health Center. And was noting that a lot of these folks, that particularly in this panel, were more of the dental aspect, but have a natural interest in FQHCs, just wanting to make sure we support them. They're oftentimes frontline, community-based clinics that are dealing with all these issues. And your role, I guess, as a credentialing manager for Choptank, right? If you could just to go a little bit more deeply in how this bill addresses some of the challenges that you're seeing when it comes to the credentialing piece, and at some of our most burdened FQHCs, yours is obviously on the Eastern Shore, but we have a lot in Baltimore City and some rural locations too.
Well, it starts with, of course, getting the provider onboarded and insurance enrolled. And we try to do that as quickly as we can. We follow HRSA guidelines for credentialing, which are very rigorous. And so we're pretty assured that that provider is ready for insurance enrollment when we send those applications in. So we prepare those and then we wait. In the meantime, patients are trying to get in with the providers. We need to get the providers started. And we're either seeing patients before we have the approval, and many times without getting paid for those visits.
Got it. Okay. That's helpful to understand. It sounds like it's pretty burdensome to be able to address that. And, it sounds like this bill could be really helpful in helping with that.
It would.
Okay.
It would reduce the wait time, so we get those providers approved and those patients seen and the reimbursement so that we can continue for our mission to see the patients.
Especially for our frontline FQHCs. So, thank you. Thank you, Madam Chair.
Thank you, Senator. I don't see any further questions. Thank you to this committee.
Thank you, Madam Chair.
Next, we have unfavorables, Matt Celentano, Allison Taylor, Kimberly Robinson, and it looks like Michael Johansson showed up in person instead of virtual. Come on up.
How could I miss this, Madam Chair?
I can't wait to hear why this is unfavorable. Because it's a really important issue, and we need to fix it.
No, I got
So,
it.
who would like to?
I'll start on that. We do agree it's a very important issue, and we are opposed as introduced, but think there's room to work on it. To the time frames, last year we did work with some delegates from the Eastern Shore on a bill to expedite credentialing for behavioral health providers, and we moved from 120 days to 60 days. That's the same standard that's in Virginia, and so if we could move to that approach, I think we'd be a lot of the way there. So I'll stop there.
You're telling me you think we can get there?
I think we can get there.
Thank you, Allison.
Madam Chair, Matt Celentano on behalf of the League of Life and Health Insurers, opposed to the bill as introduced. But as you heard from Ms. Kaufman earlier, we've already been talking to the proponents. We are in discussions on what the timelines could look like to sort of modernize the credentialing system. And I think that we are going to get to a product this committee can be proud of. So thank you very much for the opportunity.
This year, Matt? This
Yep.
year. Okay, thank you.
Thank you, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. Along with my colleagues, we have been in conversation with the proponents. As Ms. Taylor said, we do think that 60 days, which is a standard that we have been pushing towards and have now had adopted in Virginia, is something that we can achieve, and are happy to work towards that goal with the proponents of the bill to get there. I just wanted to say for the record, carriers do not credential providers to make their lives more difficult. It is something that is required by federal programs like CMS for Medicaid. It is something that we have to do for liability reasons because we are putting forward those providers to our members, and we need to make sure that they are in fact licensed and have their education as being accurately represented, et cetera. And so it is not a process that I think either side loves, but it is certainly important for the people who rely on that as a recommendation essentially of that provider. So we are happy to continue to work with them to make sure that we're doing this in the best way possible to meet our requirements, but also try to limit as much pain as we possibly can for our providers who are really important partners in this.
Thank you. Mr. Johansson?
And I've got to be nice now. So I'm Mike Johansson on behalf of Maryland Physicians Care, MCO. Medicaid managed care organizations in Maryland are obviously serving a large number of individuals and have large provider networks. We have 30,000 providers, for example. We process more than 2,000 credentialing applications a year. And one piece that hasn't been mentioned, a credentialing committee is made up of independent licensed physicians who don't have any relationship to the MCO. They have to be independent. So they're volunteers, they're not paid. They make the absolute final decision. No staff person in the MCO can make a decision to say yes or no, only that credentialing committee. It's a committee, they meet like you, they look at the information and they make a decision. I would suggest perhaps one slight modification to the 60-day timeline would be if that committee determines they need to hear an explanation from a physician about a prior event, or perhaps they have a substance abuse problem, but they're clean and they want to understand that the physician is capable of providing these services in lieu of an absolute we can't do it before the 60 days, so we're going to deny you. Perhaps if we can add something where we send notice to the provider, if they consent to an additional 30 days to give the committee time to make that final determination, I think that that would be helpful. Frankly, with respect to the other issue with respect to FQHCs, FQHCs are critically important in the Medicaid network. And in fact, when we have a new provider at an existing FQHC, we often credential them on a provisional basis so that we can pay their services even though they aren't fully credentialed by us. So we want the FQHCs to see those patients, and we will pay them. And that is in the current law, page 11 of the House bill, line 21, Senator, if you want to look at it. But carriers have the ability to make those kind of presumptive credentialing opportunities, particularly in Medicaid.
Thank you. I don't see any, oh, Senator Mounts, I do see it.
Thank you for being open-minded and coming to the table and talking about getting to a resolution. And, you know, there's a lot of experience, and you know, we pick up on things anecdotally. And do you have information on the number of doctors that are denied credentials? I mean, is there statistics on that? And do you have statistics on the amount of time it takes to get credentialed right now? You know, to base a decision off, I mean, do you have that type of basic information? You know,
we can provide it.
To kind of know, to understand kind of where we are with all of this?
We can ask.
That would be very helpful. And with regards to that committee, that's very interesting. I wasn't aware of that because it, you know, comes up in different forms or fashions. But if there's other information about how that credentialing is done, I'd be interested to know if there's some nuances. But anyway, thank you for keeping an open mind. I wanted to lead in with a bunch of really strong questions, you know, but that really doesn't, that puts people at odds. We want people to come together. So thank you.
Thank you. Thank you, Senator. I don't see any other questions. That ends the hearing on Senate Bill 808. George is here to present Senate Bill 813 for Senator Hayes. And George, you have Dan Daugherty and Stephen Dargan, and then we'll have Charles Doring on virtually. You're getting a lot of experience at this, George. Just start when you're ready.
Great. Good afternoon, Madam Chair and members of the Senate Finance Committee. For the record, my name is George Reith, and I'm here to present Senate Bill 813. Senate Bill 813 is designed to improve patient access to dental care while reducing the financial and administrative burdens on Maryland families. Under current practices, many dental plans prohibit patients from assigning benefits to a dentist if that dentist is considered out of network or non-preferred. Because of this restriction, patients with insurance coverage are often forced to pay the full cost of their dental procedure upfront. Patients must then wait for the insurance company to mail a check to their home to settle the account. When insurance checks are mailed directly to the patient, it frequently leads to confusion and collection issues because the patient may not realize the funds need to be turned over to the provider. This legislation creates parity by extending the exact same rights to dental care that patients currently enjoy with their physicians. By simply adding the word dentist to existing statutes, we ensure these protections are uniform across medical and dental care. This bill explicitly prohibits insurers and the dental plan organizations from refusing to directly reimburse a non-preferred dentist when the patient has assigned their benefits. To ensure total transparency, Senate Bill 813 includes strong consumer protections requiring the patients to be fully informed before receiving care. Before a non-preferred dentist can accept an assignment of benefits, they must provide the patient with a clear disclosure statement. This mandatory disclosure must inform the patient that the dentist is a non-preferred provider. It must notify the patient that they may be balance billed for covered services or charged for non-covered services. The dentist must also provide an upfront estimate of the cost of services. Finally, the disclosure must outline specific terms regarding payment and any applicable interest. Ultimately, this legislation streamlines the payment process, reduces out-of-pocket friction for our constituents, and ensures upfront transparency regarding healthcare costs. I respectfully urge a favorable report on Senate Bill 813.
Thank you, Madam Chair, members of the Finance Committee. My name is Dan Doherty. I'm here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. I think Mr. Reith has really outlined the bill perfectly. The only thing I would add with respect to the bill is that it adds dental plan organizations as those types of carriers that are subject to an assignment of benefits. Dental plan organizations are unique to dentistry. There aren't comparable types of organizations in other areas of practice. And therefore, in order to have all patients under dental plans have the ability to assign benefits to their provider, we need to add that in the bill. But the language totally mirrors what is an existing law for physicians. I know the hour is late, so with that, I would urge a favorable report.
We have a lot more to go, Dan. It's not that late. Thank you.
I don't have to add to that, though.
Good afternoon, Madam Chair, members of the Finance Committee. I'm Dr. Stephen Dargan. I am a dentist, general practice dentist in Calvert County, and currently the Legislative Affairs Chairman for the Maryland State Dental Association. I and we are in support of Senate Bill 813. I do want to emphasize the fact that what we're asking for with this direct payment, the assignment of benefits, has been the case for medicine for years, and we're just asking to have parity in that. When the payment does go to the patient instead of the dentist for these non-network dentists, what happens is one of three things. This is what I've experienced and my colleagues. The patient receives the payment, and then it's never forwarded to the dental practice. Or the dentist requires that the patient pay up front the entire fee. They have the patient has financial situation in which it's difficult for them to wait to be reimbursed by the insurance company. So consequently, they postpone needed treatment, which needed dental treatment can become worse and more involved. And then number three, the employer will change their insurance plan, and so consequently, their dentist provider is no longer in that network. And so the patient has to leave or decides to leave the practice, even though they're longstanding patients, and this severs the doctor-patient relationship that has been established over that length of time. Therefore, please support Senate Bill 813. Thank you.
Thank you. And virtually, we have Dr. Doring. You want to unmute and give us your testimony, please?
Thank you, Madam Chair, members of the Senate Finance Committee. Charles Doring, general dentist in Rockville, Maryland. Thank you for the opportunity to speak in favor of Senate Bill 813. And I think I set a record today. I saw a 102-year-old female patient this morning, and I just finished with a 2-year-old. So thank you for the opportunity to speak on favor. My only comments, and I echo the previous speakers of the panel, is the American Dental Association has a dental claim form. The Council on Dental Benefits works with insurance companies, and they've come up with one single dental claim form, and I have one in front of my staff. Printed one. And in box 35, where the patient signs, it clearly states, I hereby authorize and direct payment of the dental benefits otherwise payable to me directly to the below named dentist or dental entity. And so what happens is the patient signs this, they anticipate that the payment would come to the dental practice, but doesn't. They get a check at home. They may or may not know what it is, and then my staff's on the phone trying to track down the payment. So I do think if the carriers would abide by this as required in this bill, it would improve patient-doctor relationships. So on behalf of the Maryland State Dental Association, as their president, I ask for your support in Senate Bill 813. Thank you.
Thank you, Dr. Doring. I don't see any questions. That was easy. Ends the hearing. Thank you very much.
Thank you.
Thank you.
Senator Giles going to come up and take over. We're doing Senate Bill 794, Health Insurance Special Enrollment Period for Pregnancy. We have Senator Lamb, Joanna Fabian Marks, Michelle Everly, and Robin Elliott.
All right. Whenever you're ready, Senator.
All right. Good afternoon, members of the Senate Finance Committee. For the record, Clarence Lamb, Senator District 12, here to present SB 794. And this is Health Insurance Special Enrollment Period for Pregnancy Coverage. And so to rewind the clock a little bit here, in 2019, I'd sponsored SB 36, which was unanimously passed by the General Assembly, and established a 90-day special enrollment period for individuals whose pregnancy is confirmed by a healthcare provider. Prior to that law, special enrollment periods were available for major life events such as marriage, divorce, or the birth of a child, but not that of pregnancy itself. The policy change allowed pregnant individuals to obtain insurance coverage earlier and access essential prenatal care. According to a January 2022 report from the Maryland Health Benefit Exchange, between February 2020 and December 2021, the pregnancy special enrollment period enabled 762 pregnant individuals, nearly one person per day, to gain coverage during pregnancy. However, implementation of the law revealed an unintended barrier. Under current statute, coverage must begin on the first day of the month in which the pregnancy is confirmed. As a result, individuals may be required to pay multiple months of retroactive payments. For example, if pregnancy is confirmed in September, but a plan is not selected until late November, coverage is actually backdated to September 1st under the current statute, leaving the individual responsible for the payment 2 months of premiums before they even realize the start of coverage. This exposes mothers to unintended financial costs during this vulnerable period. SB 794 provides a simple, targeted fix to address this issue. The bill gives pregnant individuals the ability to choose their coverage to begin on the first day following plan selection, or continue to have their coverage begin on the first day of the month of pregnancy confirmation. If no selection is made within the 90-day period, the carrier will choose between these options. This legislation does not reduce benefits or change eligibility. It simply adds flexibility and choice. Other special enrollment categories already allow coverage to begin the month after plan selection, with states such as Virginia, where they are able to also have similar flexibility. The Maryland Health Benefit Exchange has indicated this technical change will have minimal operational impact. And so overall, the bill removes an unintended financial barrier, improves access to prenatal care, and continues Maryland's commitment to better outcomes for parents and babies. I'm told that by Mr. Celentano that the League of Health Insurance, Life and, well, whatever the league represents, their long title. I'm surprised, but pleased that they are not opposed to this bill. So, appreciate that. And with that, let me turn over to other members of the committee, and at some point I'll get the league's full name correct. So.
All right, thank you very much, Senator. Joanna?
Thank you to the committee. I'm Johanna Fabian Marks, Deputy Director of the Maryland Health Benefit Exchange. I'll keep my remarks short. As Senator Lamb mentioned, the bill, I think, aligns with the original intent of the legislation to make coverage accessible to pregnant individuals and their children, and it would be consistent with the way we operationalize our other special enrollment periods and giving that choice to have coverage start on the first of the month after the individual chooses their plan. So I'll keep it to that, and I request a favorable report on Senate Bill 794.
Thank you very much. Robin?
Good afternoon. I'm here today on behalf of the Maryland Community Health System. You just heard from them. They're a group of FQHCs, as well as the American College of Nurse Midwives, in full support of this bill. With that, we ask for a favorable report. Thank you.
Thank you very much. Are there any questions from the committee for this panel? All right, seeing none, thank you very much for your testimony. And we have one favorable with amendment, but she is not on, so that ends the bill hearing on this bill. All right, next we will hear from Senator Reedy, Senate Bill 837. And it looks like we have on your panel Michael Patty and Derek Flowers.
Thank you very much. Yes. Do I have anybody else up on the panel?
I think it's just us.
Okay.
You can invite them up if you want.
Thank you, Madam Chair, Vice Chair, and members of the committee. I appreciate the opportunity to be here today to present Senate Bill 837. And I want to start out by saying something very candid and straightforward. I have not been and have not voted for government price setting mechanisms like upper payment limits. Let's just put that on the table. I'm a competitive market, transparency, and fiscal discipline kind of guy. But the PDAB framework is now law. That's the law here in Maryland, and the board is moving forward under its statutory authority. And so the responsible course really for us as a committee and as a body is this. If the state of Maryland is going to set an upper payment limit on a drug because it's deemed to be unaffordable or have cost concerns, then we have an obligation to ensure that action translates into real access and real measurable benefit for patients. And that's the purpose of Senate Bill 837. We had a January 15th briefing here in the committee about PDAB, and members asked lots of serious, thoughtful questions. I feel like almost everybody in the committee asked a question or two at least. And we heard that the board has made preliminary affordability determinations for drugs like Farxiga, I don't ever pronounce that one right, and Jardiance, and is moving towards upper payment limits for them. The UPL is the board's primary implementation authority, and it's a price ceiling. It's a price ceiling. Patient savings may depend heavily on the benefit design that they're in, and especially in co-insurance structures. Transparency into PBM net pricing also remains extremely limited. So the exchanges that we got back and forth with those questions, and the hearing is one that I think could be fruitful and for anybody to watch again, they highlighted something very important. A price cap by itself does not guarantee patient access, and it does not guarantee lower out-of-pocket costs for our constituents. If a UPL is imposed, but then insurers respond by increasing deductibles or shifting tiers on drugs or adding prior authorization and step therapy, additional step therapy. The intended benefit may not reach the patient, and in some cases could end up somehow worse, I think, in some cases for patients as far as an access perspective anyway, for sure. And that's the gap this bill is trying to address. So really to understand kind of where we are on access and the landscape there, Value of Care Coalition, and I've got some folks here from Value of Care, did a formulary analysis. The top lines of that analysis are in my written testimony, and it's actually hyperlinked. This analysis examined how the 6 drugs that are currently under PDAB review are treated across carriers and markets. And it's really interesting. The findings are really interesting. There is significant variability in tier placement across carriers. Some drugs are placed on Tier 5 specialty tiers and include a high coinsurance cost. Prior authorization and quantity limits are common. Step therapy is frequently applied to these diabetes drugs like Jardiance. And in some markets, certain drugs can even appear as no coverage. So the takeaway here, by the way, and we'll hear from our friends and our allies in the health marketplace, the insurers, we'll hear from them, I know we will at the end of this hearing, that they're not necessarily supportive of the bill. But the takeaway here is not that insurers are acting improperly. The takeaway really is the access is inconsistent once these limits are set. And inconsistent access is not what we want. That would be wrong. That would not be good in Maryland for our consumers and our constituents. So if Maryland determines that a drug creates affordability challenges and caps its price, but insurers retain full discretion to tighten access or increase cost sharing, then what's the point of the pricing cap? There's no real benefit to patients. So we need to ensure that we have a policy coherence between pricing decisions and patient access. And this is definitely not, I know people get up here all the time and say it's not a partisan issue. This is definitely not a partisan issue. It's not a right-left issue. It's sort of a right and wrong issue. If we're going to set price caps, we really cannot afford to say, well, it's capped in price, but good news or bad news for you, Jimmy or Susie, you get to still pay the same price, or, well, good news, it's cheaper, but you've got to jump through 3 hurdles to get medication that you used to just be able to access. It's not what we want. Now, PDAB, they are not here, I don't believe, to testify today, but we did talk with Dr. York and the team there and had some really good conversations with them, and we will continue to do so. Dr. Andy York raised 2 specific concerns about the bill as introduced, which is why we have amendments. So this bill, I'm going to talk about the bill as amended and explain the amendments. And the concerns were fair and thoughtful, and we've addressed them with these amendments that I've submitted with my testimony, so I want to talk about those for a moment. The key here, I think the immediate suspicion was somehow we're trying to undermine PDAB or the PDAB process. We're not. We don't want to mess with anything they're doing on their analysis. Quite the opposite, actually. If we're going to do this, we want to do it right. We want to be sure it's done right. Dr. York was concerned that the bill could be interpreted as intervening before the board completed its cost review work, and I understood that. So the amendment resolves that clearly. This protections in SB 837 as amended apply only when a PDAB set upper payment limit is formally in effect. Not during cost review, not during preliminary determinations, and not certainly during information gathering or testimony. Only after the board has completed its statutory process and actually established the UPL would this bill take effect. This bill doesn't interfere with any sort of analysis or try to predetermine any outcomes. It's only at implementation that this bill would take effect. Concern number 2 that Dr. York raised and their team was if a UPL was set in one market, such as Medicaid, that this bill would automatically impose restrictions across all markets. The amended language clarifies these guardrails that we're putting in would apply only in markets where there's an upper payment limit actually in effect, and if there's no upper payment limit in a given market, then the bill doesn't activate those restrictions. I thought it was important to clarify sort of the broader market applications and how it works under Maryland's PDAB statute. Under the PDAB expansion law we passed last year, upper payment limits initially apply only to state and local government purchasers. The board gains authority to apply upper payment limits to all payers, but only after at least 2 upper payment limits have been implemented. These UPLs have been in effect for 1 year, And 3, the board provides the required notice to DLS, Department of Legislative Service. So at that point, the board can exercise expanded authority to do UPLs more broadly, but a broader application does not occur automatically without board action. This bill does not alter or accelerate that statutory trigger. It does not automatically expand PDAB's authority into new markets. It simply ensures, this bill simply ensures, as amended, that wherever a UPL is in effect, appropriate access protections accompany it. Because again, what would be the point of setting an upper payment limit and capping a price if the consumer can't benefit from it and loses access to it? That would be counterproductive. So as amended, for drugs subject, in this bill, for drugs subject to a PDAB set upper payment limit, insurers and Medicaid managed care organizations may not require prior authorization, impose step therapy or fail first protocols, remove the drug from the formulary, which is something we've seen in other states, we've seen this in all of these other states, move the drug to a more restrictive formulary tier, increase co-payments, co-insurance or deductibles, not that they're getting rid of those, but it can increase them, and it cannot reduce or limit prescription drug benefit coverage. There is a narrow exception if the FDA raises a safety concern, obviously, or if the drug is discontinued, and these protections will apply only in markets where a UPL is in effect. So whether somebody supports or questions upper payment limits as a policy tool, which I certainly have had my share of times I've questioned it myself, but once the state exercises that authority, and certainly we as a body have overwhelmingly given them that authority, once the state exercises that authority, the state also has a responsibility to ensure that the decision has real-world meaning for our constituents, not just save money for the bureaucracy or the insurance company. And a price cap without access protection is a cosmetic price cap. So this bill, again, as amended, ensures the board's affordability determination is respected, the state's pricing action is not offset through some sort of benefit design that's unique because of the UPL, patients experience real benefit, implementation matches our legislative intent. So this is a very targeted approach to make sure we're properly sequencing upper payment limit being set, access, and affordability for consumers to follow. And the amendments work to address the concerns that PDAB raised to us. And we also tried, as I said, to look at the questions that were raised in the hearing back in January 15th. And finally, the fiscal note. The fiscal note is fiscal notes are static. The fiscal note is a warning, not a fiscal model, is how I would characterize it. It reportedly says that impacts of this bill are indeterminate but significant. It also suggests that the cost could reach tens of millions of dollars or grow exponentially. But it does not provide a transparent methodology explaining how those projections were calculated. We're missing prior authorization denial rates, appeal and reversal rates, how many patients would actually start a particular therapy, and there's other items as well. So without those inputs, the projections from these fiscal notes are basically directional assumptions, and they're not an estimate that I think we can make final decisions on. The fiscal note also ignores the role of the Prescription Drug Affordability Board. Because this bill only applies to drugs that a UPL has been set by PDAB. And boy, we are in acronym heaven right now, UPLs and PDAB. PDAB's purpose is to address drug affordability directly, and that includes that authority to set the UPLs. And the fiscal note, it focuses kind of entirely on increased potential utilization. So it doesn't account for potential cost reductions from PDAB affordability and other items. So just wanted to lay that out there. I appreciate the indulgence, Madam Chair. It's a lot to get through, but it's a complex issue, but it's real simple, real simple. We don't want the upper payment limit being set and then it not benefit consumers at all. And in fact, in some cases, be worse for consumers and for our constituents. The patients have to come first. And if patients do not have proper access or access is more limited, and certainly and I also say if we're not getting real savings for them, then it's not good. So that's why I put forth this bill, and I would ask for the the committee's support, and of course happy to work with folks that do oppose it now if we can try to mitigate some of those concerns. I know some of the people who opposed it had not seen the amendments yet, so we'll work on that. But with that, I'll turn it over to my panel, Madam Chair. Thank you so much.
Thank you. Who's next?
Thank you, Chair Beidel and members of the committee. Thank you for the opportunity to speak today. My name is Derek Flowers with the Value of Care Coalition. We're a network of patient, provider, and caregiver organizations, and I'm here today in support of SB 837. I also want to thank Senator Reedy for sponsoring this important legislation. Maryland has taken action to address prescription drug affordability through its Prescription Drug Affordability Board. The board's primary tool for setting upper payment limits. That's caps on what health plans and payers can reimburse for certain drugs. That authority affects plan payments, but it does not automatically change what patients pay at the pharmacy counter or how plans design their benefits. And that's why without this legislation, any progress may never reach patients. The findings of our Maryland Health Plan formulary analysis and a national survey of health plan payers conducted by Avalier together tell a clear story. Currently, for the 6 PDAB-reviewed drugs in Maryland commercial markets and in Medicaid, we found extensive requirements for prior authorization and step therapy. Several carriers place these drugs on specialty tiers with high coinsurance, and formulary exclusions, meaning there's no coverage at all, is all too common. So before any UPL has even taken effect, patients are already facing significant access barriers. And unfortunately, health plans are telling us it may only get worse once UPLs take effect. Survey data shows 67% of payers anticipate patient cost sharing will increase or stay the same with the UPL. 50% expect utilization management to go up on a UPL drug, and 50% anticipate higher copays or coinsurance on a UPL drug. And that's why this bill is necessary. Patients are at the mercy of their health plan when it comes to out-of-pocket costs and access to the medicines they need. SB 837 ensures that if a UPL is implemented, plans cannot respond by shifting costs to patients or putting new barriers in place. With Senator Reedy's amendment, these protections apply only to drugs subjected to a UPL and in markets where a UPL is actually in effect. If Maryland is going to cap what plans pay, we must ensure that patients see that benefit. For these reasons, we respectfully urge a favorable report on SB 837.
And Michael Paddy, also here on behalf of the Value of Care Coalition in support of the bill with amendments. I want to thank again Senator Reedy and also Ms. Tran to get these amendments in order. It was not easy to boil down what we were trying to get, but we got there. I think at its core, this bill does not change any of the statutory authority of PDAB. It keeps that part of the law absolutely intact, and it takes their final work product and applies it, when appropriate, to Medicaid and to commercial insurance plans. You know, we should be building on the work of a state agency and utilizing it to the best of our ability. I want to thank again Dr. York and PDAB for highlighting their concerns, and the Maryland Healthcare for All for again highlighting where it got a little murky, and these amendments hopefully address those issues. You know, PDAB at its core, upper payment limits, that is the final step that they have. After that, it's just maybe a report or two, and then it's on to the next drug. And we really want to make sure that all the work that this committee's done, that this General Assembly has done, and the work of PDAB has done over the last 7 years is meaningful to the patient when they get their insurance bills and when they go to the pharmacy counter. So with that, I would ask for a favorable report with the amendments. Thank you.
Thank you. Senator Mounts?
That was a lot of testimony. A lot of testimony. Can you just give me a 30-second to 1 minute of how we're doing this, how it works, rather than all of that information? That was a lot of information. Can you, I don't know if Senator Reedy, the sponsor, or who would be the best, just to, you know, give it to us straight, you know, about how this is going to ensure that the upper price limits are actually going to get passed on to consumers. Can you?
So there may be people that can answer it more technically. Very simply, the goal of the bill and what the bill has drafted is, if we're setting an upper payment limit, we do not want then downstream for the insurance company or managed care organization to basically be able to raise the price of the copay, add additional hurdles to additional step therapies that get in the way of the patient to get access to the drug.
Right.
We want the savings to be passed on to the consumer, or at the very least, if the savings get eaten up in bureaucracy, we at least don't want access to be made worse. And so that's the goal of the bill, is to ensure the access part, the access and affordability getting to the patient. If you just set an upper payment limit, but then the people involved with administering it all can just make it harder to get as a way to absorb, to make up for the cost.
So it's more of a preventative measure than to
It is,
ensure
because-
that costs aren't added on to consumers, rather than it doesn't actually lower the cost for the consumer. It's just ensuring that consumers aren't bearing the burden of hidden additional costs to recoup from reductions that are implemented by this.
Yeah, that's
entity.
exactly right. If the UPL is meant to increase affordability, then let's make sure that happens. Someone earlier up here today said affordability is accessibility, and that stuck with me. But what we're hearing from insurers with regard to upper payment limits is that even if the PDAB reduces the top line price, there's no guarantee of access. This bill would prevent that from happening.
Right, and of course, we don't know yet because we're still in process.
Correct.
Thank you.
But we do know that in other states, we've seen access issues.
I'm sorry.
In other states that have a PDAB, we have seen some of these issues. So that's what we're trying to avoid.
Thank you.
Other questions? Seeing no questions out on this panel, we're going to bring up April Gutman, Vanessa Lathan, Kelly Schultz, and Andrew Zirkle. Or maybe Andrew instead of Kelly, right? Got it. Thank you.
Madam Chair and members of the committee, my name is April Gutman, and I'm speaking on behalf of the Diabetes Patient Advocacy Coalition, or DPAC, in strong support of Senate Bill 837. DPAC is a national alliance of people with diabetes, caregivers, health professionals, and advocates working to improve the lives of those living with and at risk for diabetes and its complications. We are an organization run by and for people with diabetes, focused on ensuring access to medications, technologies, and the care our community depends on every day. Over the past year, we have actively engaged with the Maryland Prescription Drug Affordability Board to ensure the patient perspective remains central to affordability discussions. We have consistently emphasized two priorities: reducing patient out-of-pocket costs and protecting uninterrupted access to medically necessary therapies. We strongly support efforts to make prescription drugs more affordable. However, what patients pay at the pharmacy counter is largely determined by insurance benefit design. Deductibles, coinsurance, formulary placement, and utilization management tools like prior authorization and step therapy. Without clear guardrails, system-level payment reforms such as upper payment limits may not result in lower out-of-pocket costs for patients. Instead, insurers could respond by adding new restrictions, moving medications to less favorable tiers, or increasing administrative barriers that make it harder for patients to access the treatments their providers prescribe. For people with diabetes, access disruptions are not theoretical. They have immediate health risks. When someone who has been stable on a medication for years suddenly faces a delay, denial, or forced switch, blood glucose levels quickly deteriorate. That can lead to emergency department visits, hospitalizations, and long-term complications such as kidney disease, vision loss, cardiovascular events, and amputations. Senate Bill 837 is critical because it recognizes this risk. We respectfully ask for a favorable report on the bill. Thank you.
Madam Chair, good afternoon. It's good to be here again before the Finance Committee. For the record, my name is Andrew Zirkle, and I'm here on behalf of the Maryland Tech Council in support of Senate Bill 837. A lot of my thunder was stolen by the sponsor and his panel, so I'll try and keep it short. We'd like to thank the sponsor for introducing this legislation, which we would expect to improve access to medications that are reviewed by the Prescription Drug Affordability Board. As members of the PDAB Stakeholders Council, MTC has consistently expressed that we believe UPLs are not the silver bullet in solving the patient access and affordability problem, and that other measures should be considered. We are confident that the reforms in this bill will benefit Maryland patients by improving access to medication, by reducing the administrative burden for providers and patients, and by aligning insurance practices with PDAB affordability determinations. We believe that there will be benefits when it comes to prohibiting unnecessary prior authorization, step therapy treatments, and discriminatory formulary adjustments. As an additional aside, By removing patient access barriers through this bill, you're sending a positive signal to Maryland's 2,700 companies and 5,400 workers in the life sciences industry that are responsible for testing and developing and manufacturing these critical medications. With all of that and the critical benefits to patient access considered, we ask for a favorable report on Senate Bill 837. Thank you.
Thank you. I guess Vanessa? Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Vanessa Lathan, and I'm a patient living with multiple chronic health conditions with the Patient Inclusion Council. I have lived in Maryland Senate Districts 11, 42, and 43, and I respectfully urge the committee to have a favorable report for SB 837. The Patient Inclusion Council recently conducted patient-led research with 537 respondents, including more than 90 Marylanders. What constituents told us was clear. Affordability is not defined by drug price alone. For patients, affordability means being able to consistently access medication that works for them without insurance barriers interrupting their care. 95% of patients who stopped the medication said it was due to insurance barriers such as prior authorization, step therapy, or coverage denials, not the price of the drug itself. 72% of patients who never started a prescription medication cited the same barriers. Patients also described affordability shifting and access shifting, meaning insurance challenges can suddenly increase out-of-pocket costs or change coverage, making the same medication affordable at one time and unaffordable at another. This interrupts treatment and creates real hardship for patients trying to manage chronic illness. We also heard about the harms of non-medical switching, where patients are forced to change medication for insurance reasons rather than medical ones. These challenges lead to disease flare-ups, side effects, and worsening health outcomes. More than 80% of patients who have tried multiple treatments describe their current medication as uniquely effective for them. For people with complex chronic conditions, treatments are not interchangeable. Last year, the Maryland Insurance Commissioner testified that her office cannot prevent insurers from increasing out-of-pocket costs or moving PDAB review drugs to a higher cost-sharing tiers. That makes legislation action necessary. Thank you for your time consideration.
Testimony. Do I have any questions for this panel? Seeing no questions, thank you all for your testimony. Now we have a panel of unfavorables. Joseph Wynn, Matt Celentano, Vincent DeMarco, Allison Taylor, and Kimberly Robinson. Starting to be the Three Musketeers.
Madam Chair, in the order you called them? In the order you called them?
Doesn't matter.
Thank you, thank you. Good afternoon, everybody. Madam Chair, members of the committee, it's nice to see you. For the record, my name is Joe Wynn. I'm the Executive Director of the Maryland MCO Association. The Maryland MCO Association represents all 9 Medicaid MCOs that arrange and finance care for nearly 1.3 million Maryland residents. I had prepared remarks, but I hadn't seen the amendments that Senator Reedy shared, but I do want to raise a few issues. Maryland, as you know, is the first state to create a PDAB, primarily because prescription drugs continue to outpace medical inflation at a regular clip every year. And the MCOs are very worried about this, as all the other payers are as well. I'm sure they'll say so. The prior auth function for prescribing drugs isn't about costs. It's about a number of issues that are not addressed by the amendment, with all due respect, Senator. There are things like drug-to-drug interaction, contraindications that are unique to the individual member. There are therapeutic duplications, improper dosing, allergies, overuse, and a number of other elements that the process of prior auth helps find in conjunction with our pharmacy partners. The pharmacists are the gatekeepers, the final decision makers, but rely on the information they receive from pharmacy benefit managers and others involved in the review process. We continue to have concerns about the MCO's ability to adjudicate these and have a request for an unfavorable report on the bill. Thank you.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson, again, on behalf of Care First Blue Cross Blue Shield, respectfully requesting an unfavorable report on the bill. And I really do appreciate getting to hear the proponent's testimony, and I really do appreciate Senator Reedy for his well-intentioned bill. I think Mr. Nguyen really hit on what is the crux of our concern, is that this bill confuses cost with utilization management. And as you just heard from Mr. Nguyen, those two things are really separate. And the way that a carrier builds their pharmacy tiers, the way that we determine which drugs may be subject to something like a prior auth or a step therapy is not rooted in the cost of the drug. Often, there are many other elements that are going into making those decisions about how those drugs are going to be covered, where they're going to be placed, and how they're going to appear within the policy. And so to take the PDAB, who in its review of the drug is taking none of those other things into consideration, who is not taking into its evaluation any of the things that go into how one builds their formulary, they are focused exclusively on cost and then substituting cost for all of the other factors. For us is a mismatch, and it is problematic, and that is really what our challenge is with the legislation that's before you. It is taking that cost and then translating it to another space and then using cost as a substitute for something to which it's not directly aligned. And so for that reason, we would urge an unfavorable report on the bill. In terms of the concerns that the good sponsor did bring up, we are happy to talk about some of those other things and to have a deeper conversation about utilization management with you or any of the proponents of the bill, but this is why this bill is a concern.
Madam Chair, members of the committee, Matt Celentano, still here on behalf of the League of Life and Health Insurers in opposition to Senate Bill 837. First and foremost, I am really happy to be sitting next to Mr. DeMarco. This bill fundamentally confuses the role of the PDAB. The PDAB is designed to look at the affordability of drugs where costs may otherwise impact patient access. To date, the PDAB has only looked at a few drugs, and those are the ones that we're gathering information on are the so-called poster problem children drugs of the ones on formularies. Medications that have list prices that do not match efficacy, therefore requiring review. Just because the PDAB does not take action by no stretch means that the drugs, bless you, don't pose an accessibility challenge for consumers. Step therapy, utilization management, prior authorization, while accounting for the cost of the drug, are grounded in the clinical efficacy and evidence that is needed to justify a particular drug's use in a particular patient circumstance. These are critical tools in the absence of PDAB action. Saying that the PDAB inherently eliminates the need for utilization management is like saying, I ate a vegetable today, therefore I never need to eat a piece of fruit ever again. All right, we respectfully ask for an unfavorable report on Senate Bill 837.
Well, I can't be as witty as Matt, but thank you, Madam Chair, Mr. Vice Chair, members of the committee. First of all, I'm Vinnie DeMarco with Maryland Healthcare for All Coalition. Thank you again for enacting the original PDAB in 2019 and Senator Giles' wonderful bill in 2025 to expand the authority to everyone. It is really wonderful. And I just want to update you that another state based on Maryland's model on October 3rd of last year enacted the first upper payment limit on a drug called Enbrel, which will save people in Colorado $32 million a year in less spending. And it has not been in place yet, so it couldn't have caused any of the problems to utilization or anything like that. So we are excited about the PDAB. It's about to make high-cost drugs more affordable for state and local governments in Maryland, and soon after that for everyone. We oppose this bill as same reasons that the PDAB opposed it, because it would undermine the work of the board and put it into areas, as you heard from the other panelists today, that it should not be in, and cause additional delays beyond which would have had to happen to get to this point. Now, like the other members of the panel, we appreciate Senator Reedy's amendment, which in our opinion does reduce the problems of the bill. We have not had a chance to look at it carefully, and the board has, and the PDAB certainly has not, and we will follow the lead of the PDAB on the review of on this amendment. But I want to emphasize the PDAB is working. PDABs around the country are working. They are not causing problems. In fact, they are saving money for consumers in state and local governments. And we urge you to reject this bill and keep the PDAB in place without undermining its authority. Thank you very much.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. I do want to thank the sponsor for sending me the amendments today. And in the interest of time, I'll say me too.
Thank you, Allison. Senator Reedy?
Thank you, Madam Chair. I'm curious about a couple things. And I actually, it's been interesting to go through this process. When there are specialty tiers created with higher out-of-pocket costs for patients, why does that happen? Is that for patient safety? Is it for cost? For our insurer friends, yeah.
Senator Reedy, thank you for the question. So specialty drugs are often treated as their own category of drugs under insurance policies, as you mentioned. In fact, here in Maryland, Maryland has a statutory definition of what is a specialty drug that exists in our insurance code. I think sometimes when you hear and read a lot of the things about them, they don't necessarily apply to Maryland in quite the same way because we already have a cap on how much anyone in Maryland is to pay under an insurance product for a specialty drug, you know, what goes into that specialty drug tier. And so Maryland has its own definition. It's a drug that costs $600 or more, requires special handling. There's a couple other components in the statute about what is a specialty drug in the state of Maryland. And they are often very high-cost drugs. They are often for significant medical conditions. And they often, as the law lists for Maryland, do require special handling, special administration, and for that reason are often, under Maryland law, can only be dispensed by a specialty pharmacy to make sure that that drug is being safely delivered and administered to the appropriate patient. The drug world is very complex. It's evolving incredibly quickly. Our pharmacological science has done wonders in keeping us healthy and alive for a number of conditions in ways that didn't happen 10 years ago or 20 years ago. But that is how specialty tiers come to be in a formulary. That's what really drives it, are those factors about a drug.
Well, and so for the 6 drugs that PDAB is currently reviewing, I think all of them, or at least most of them, are frontline treatments, right? So if an insurer would not cover those, where are we left with that frontline treatment?
So Senator Reedy, thank you for the question. All 6 of the drugs that are being reviewed by the PDAB are all drugs that don't have a generic alternative. So it is the only game in town for that particular treatment. All the carriers are covering all those drugs. I think our concern with that is that with this bill as related to those 6 drugs is that just because the PDAB is reviewing the affordability challenge doesn't mean that there aren't other treatments that might be just as effective and the carriers are like to address, but those drugs are all going to be on the formulary. Now, one of the bigger problems—
Well, is it guaranteed they'll all be on the formulary even if there's an upper payment limit set?
I think so. I mean, the upper payment limit is going to be less than what the carriers are paying now, is my assumption. We'll see what happens. We haven't had an upper payment limit set in Maryland as of yet, but there's a lot of things to be sorted out. The problem is, and why we have the PDAB in general, is not to talk about utilization management. It's to talk about the cost, right? Sure. So for like 10, 15 years ago, the percentage of your premium that went to prescription drugs was in the 6 to 7% territory. Now it's 35%. If we don't do something, and the PDAB is one of those tools to address those runaway, healthcare costs, we're not going to have an insurance product to sell.
But if we, okay, but so the problem with, well, I understand that. So the point is, though, why a bill that's trying to make sure you don't reduce access once the PDAB sets it up?
Nobody's going to reduce access. This is utilization management tools to make sure that it's appropriate for the patient. It's medical effectiveness. It is to review that you don't have contraindications. It's not all about cost. It's about safety, too.
So, okay, so when you talk about safety and saving money, right now, basically, if patients save money, with the health plans right now, do you think that the upper payment limits will both save money and increase access, or we're just going to save money and watch out for? I'm just trying to understand.
You can. Yeah, I think it's hard to answer because I think
you're mixing it to Matt's analogy, apples and oranges, right?
Okay.
So there's this assumption that's underpinning the bill that because the costs change, we're going to change the utilization management about it, which is particularly interesting in a space where the drug has become less expensive, right? Ironically, typically when I'm in this conversation, the concern is a drug is becoming more expensive and therefore we are not going to want to cover that
Right.
drug
No, I understand
because
that,
it's
yeah.
becoming
Yeah.
more expensive, right? In this case, what's happening in this bill is it's saying it's going to become less expensive, so we're going to be less likely to want to cover it. I'm not quite sure I follow the logic in why that would be. And it's mixing the conversation around the cost of the drug with the management of the drug. And they are actually two very different sets of decision trees that are not about one another.
Maybe I'll leave this here. Right now, prior authorization, step therapies, specialty tiers, that's all part of what you guys do in plans now as part of, as part of health benefit design, basically.
It's
correct?
traditional tools that carriers use.
Right, which is understandable, and we all understand it, whether we like all of it or not. We understand it's part of the tool. So, I mean, why though on a particular drug, if it never permanently give it set, would you have to continue doing that to that degree if we're going to cap the cost? I guess you'd have
Because
to.
the utilization management is not about the cost. That's the connection that's being made in the bill. That's not true.
But you understand if you restrict utilization more after an UPL is set, you're going to functionally you are reducing.
I don't think anybody's saying restricting utilization. It's managing the utilization.
Well, we're
so
trying
it's
to be
more
sure
than
you
just
don't.
cost. I understand that.
Right.
But when with 6 drugs, there are no therapeutic alternatives. If it is considered medically necessary,
You're going to cover it.
Correct.
Okay. All right. Well, I know we get a lot more. I'm sorry. Thank you, Madam Chair.
Senator Washington.
Thank you, Madam Chair. Does anyone here represent Healthcare for All? Oh, perfect. Of course you do. What's Healthcare for All's position on utilization management?
It is not something we've ever really looked at carefully because we've been focused on coverage and affordability. As my colleagues here said, utilization management is about something very different that is basically outside of our scope. We're here because we think this bill would undermine the PDAB, which we don't want to have happen.
But you guys haven't taken a position on utilization management?
No, it's not something we've looked at. I can understand why it makes sense, and we're not opposed to it happening, and we want anything that will make people make sure they have the drugs that they should have. And as my colleague said, it's for other reasons rather than cost, but it's not something we've been engaged in.
Let me ask you another question. Why do healthcare plans still need utilization management on drugs that Prescription Drug Affordability Board sets an upper payment limit on?
Well, that's a question for my colleagues. From our perspective, the problem is, especially with the original bill, it's less of a problem with the amendment, but especially with the original bill, it would put the board into an area that it's not designed for. It's designed for the cost. The utilization management, which involves, as my colleague said, many other factors, is what the insurance companies look at. I would really not want the board's ability to set an upper payment limit to be undermined by it being connected to utilization management. It's a separate issue.
Well, since we're talking about the Prescription Drug Affordability Board, was it your vision when we created this board for them to only look at 6 prescription drugs in a matter of 2 years?
Well, it's taken a while. And I believe that it's really hard work, and they've done their work. They've done their work well. There've been impediments, but I'm hopeful that over the next few months we will see upper payment limits for state and local governments for several of these drugs, and next year for everybody. But my hope is that once they've spent this time setting up the processes, it will be a lot easier to, in the future, do more drugs. And like you, I want them to do more drugs.
I think it's just my hope that since we voted for this and worked really hard on it, that we would actually save people some money on drug affordability,
right,
and get to a point where we actually are doing the work of the people and of the state of Maryland. So thank you for answering my questions. I really appreciate it.
And it's my understanding that over the next couple months, they will set an upper payment limit on at least 2 drugs, Jardiance and Farxiga, which will save state and local governments hundreds of thousands of dollars. And under the bill you passed in 2025. 1 year later, they could set those upper payment limits for everybody. And for those drugs, they'll save Marylanders tens of millions of dollars. And then they're going to go to Ozempic. And Ozempic, when they hit those upper payment limits, will save state and local governments millions of dollars, and everybody else many tens of millions of dollars. So we think those savings are coming.
I hope so. Thank you very much.
Thank you. Thank you for support.
Senator Lamb.
Thank you, Madam Chair. So I was looking through the bill folder and noted from some of the responses from the payers here that these utilization management tools, which have been part of the discussion here a lot, that obviously includes prior authorization, step therapy, fail-first therapy, and the like, are used in order to follow certain clinical guidelines and also to address safety-related issues. But from the perspective of the provider, isn't this what physicians are supposed to be doing to be making these kinds of judgments? Because it really seems like these ensure that the payers now have injected themselves into this process and are second-guessing, providers' clinical decision-making here.
Yeah, I'll take a crack at that. I mean, I think what you've raised is a fundamental question that is, wide beyond the scope of this bill, a larger conversation. In the Kaiser value-based model, we do have the physicians who are in charge of this, but I think, in the fee-for-service world that most of us exist in this country, that is, for better or worse, where utilization management happens. And I think until we evolve to our next level, this is where we're at.
Okay. Well, obviously there are still instances where prior authorization are going on. Some plans require this for certain medications, while others don't. Really, if this is used as a mechanism to ensure safety and better outcomes, why isn't this being more uniformly applied then?
When you say uniformly applied, I'm not sure, uniform for whom?
This instance of utilization management.
I mean, when you say across carriers, I'm trying to figure out uniform for whom. Like, so when you say uniformly applied, who's applying it and who's not? So I'm trying to just
I think
figure out
uniformly applied to across different medications.
Well, every medication doesn't pose the same risk, right? So you don't apply utilization management to every medication because the needs that the medication the patient's need with that medication and how that medication may impact in terms of interactions, special handling, other sensitivities, right, are not the same for every medication. So no, you would not apply utilization management typically to aspirin. The same way you might apply it to a much more impactful medication that's going to have more side effects, more consequences, more interactions, all of the things that make it so that you want to pay more attention and ensure that I haven't gone to see Dr. Celentano and gotten something prescribed and then gone to see Dr. Taylor and not communicated between them that I'm on something, but my carrier can see that I'm on that drug that I failed to disclose and are able to catch it before they go ahead and just fill that prescription.
But you don't, as carriers, you don't have the same prior authorization requirements necessarily for the same medication, right? You may have different.
From carrier to carrier.
From carrier to carrier.
That's what I was trying to get at when you said uniformity. Did you mean from carrier to carrier?
From carrier to carrier.
I can only speak for my company. I don't know what other carriers necessarily apply and don't apply. I can't say for a fact that we do or we don't. I would not assume that we necessarily do, but I can't speak to the why of that because I can only speak for the carrier I speak for. I don't know why someone else maybe doesn't see it the same way I do. I probably would say my folks think that they're wrong, and they probably should be paying more attention if it's something that we are applying utilization management to that they're not, but I can't.
Well, that speaks to the point that it's not being used for patient safety issues, because if it was being used for patient safety, you probably have the same policy across all the carriers, right? And so it's really not being used to ensure patient safety or quality-related issues.
The best I would concede is perhaps not exclusively. I'm not going to concede that we're not using it for patient safety issues.
Sure, not exclusive. Okay. So I guess this is for Vinny. You know, I was looking at your written testimony. Obviously, agree that the role of the PDAB is to really focus on making drugs cheaper. I agree with Senator Reedy's concern of making sure that the cost savings are actually passed down to the patient or the consumer. But, you know, is there anything in this bill that is changing what the PDAB is required to consider? Because, you know, based on the amendments that were being suggested here, I'm not seeing us even touching, you know, kind of that section of things.
Well, we're opposed to the bill as originally drafted, and we appreciate the amendment, and we came in opposition to the original bill, partly, a lot of it, because the PDAB opposed it. And the PDAB has not yet taken a position on the amendment. So we're waiting to look to them. But our general view is we don't want more hurdles in the PDAB before it can make its decisions on upper payment limits. And injecting these ideas of utilization management, which are way beyond cost, into the decision on upper payment limits seems to me the way that would undermine and delay the PDAB's work. But I'm you know, waiting to see what the board's response is to the amendments. And it will affect everybody, not this year, but next year, because next year is when the board's authority expands to everyone. So it might be better to look at this next year rather than this year. But for right now, we believe the PDAB is about to take some really exciting actions, and we'd hate to put something in its way right now.
I mean, I'm supportive of the PDAB, obviously.
Yes, thank you.
And supportive of trying to reduce costs to consumers, to patients. And, you know, I think, but share a lot of the concerns about, obviously, when it comes to fail first therapy, prior authorization, utilization management related issues. Does the existence of the PDAB in any way bind the General Assembly's ability to regulate utilization management in the state?
I am no expert on utilization management. I'll defer to my colleagues here, but I can say, in my view, absolutely not. I mean, it's a separate matter. What the PDAB will do is make high-cost drugs more affordable for state and local governments that are being gouged by high-cost drugs. They will help individuals be able to afford their drugs and make sure that our premiums don't go up more than they should because so much of our premium now is high-cost drugs. That's what the PDAB will do. Separate is utilization management. I don't think anything in what the PDAB does affects your ability to regulate utilization management.
Okay. I mean, just to follow up on my colleague's, you know, question, I do find it humorous that Healthcare for All does not have a policy on utilization management. That seems to run counter to the charge of making sure healthcare is accessible to all in the most affordable way.
Senator, we're a small shop, and healthcare is really, but we do the best we can. Thank you.
Okay.
I don't see any other questions. Thank you all for your testimony.
Thank you.
Anybody else? One virtual. I'll turn the page. I guess I was hoping I was done. We have one virtual witness, Kinley Boyer. You want to unmute and give us your testimony, please?
Hello, my name is Kendall Boyer. Good afternoon, Madam Chair and members of the committee. My name is Kendall Boyer, and I'm here today representing the National Infusion Center Association and the 131 non-hospital infusion centers serving patients across Maryland. Our members care for individuals living with chronic and complex conditions who rely on consistent access to infusion and specialty medications to remain stable and avoid hospitalization. We are here in strong support of SB 837 and Senator Reedy's amendment. While NICA has broader concerns about prescription drug affordability boards and upper payment limits from the reimbursement perspective, today my focus is on clinical decision-making and patient access. When the state takes action to make medications more affordable, patients must be able to access those medications without new insurance barriers standing in the way. One of our Maryland members, Active Infusions, is led by registered nurses Layla Henderson and Caitlin Midkiff. They serve hundreds of Maryland patients, providing therapies for individuals with complex autoimmune conditions and a growing population of patients living with dementia. Before coming here today, I spoke with them, and they understand these barriers from both sides, as nurse leaders and, in Caitlin's case, as someone with a chronic condition herself. She has seen firsthand how insurance prior authorization requirements, step therapy protocols, and coverage restrictions are not being utilized to support patient safety, but rather they are being used to delay or prevent access to medically necessary treatments. In the infusion setting, delays are not benign. Patients don't simply wait. Their disease progresses, they lose stability, and some end up in the emergency room or hospitalized. If Maryland's PDAB established an upper payment limit on a drug, but still allows insurers to layer on utilization management strategies, it simply undermines any attempt at patient affordability and creates confusion and delay for patients and providers. SB 837 helps ensure that when the state addresses affordability, patients actually experience that benefit at the point of care. So on behalf of Maryland's non-hospital infusion providers and the patients that they serve, I respectfully urge a favorable vote on SB 837. Thank you for your time and consideration.
Thank you. Do I have any questions for this witness? Seeing no questions, thank you for your testimony. That ends the hearing on Senate Bill 837. And now our last bill of the day, Senate Bill 797. Senator Lamb, if you stand at the podium, I can get all 6 of your witnesses to the table if they're all still here. So it's Senate Bill 797, Amy Thomas, Richard Pellegrino, Dana Kaufman, Dion Watts, Aaron Murray, and Jake Whitaker. Oh, shucks, everybody stayed. Okay.
All right. Good afternoon. Thank you, Madam Chair. Members of the Senate Finance Committee, here to introduce Senate Bill 797. For the record, Clarence, I'm Senate District 12. This bill addresses the inappropriate downcoding of medically appropriate and necessary care and the impact that this practice has on patients, providers, and the healthcare system as a whole. As a physician, I want to be very clear about what this bill does and what it does not do. This legislation does not prevent insurers from reviewing claims. It does not prohibit the use of utilization management. It does not mandate payment for inappropriate or unsupported services. However, what it does is establish basic transparency, fairness, and clinical integrity when insurers reduce payment by unilaterally changing the codes submitted by a treating provider. Downcoding occurs when a claim, often for evaluation or management services, is altered after submission, resulting in lower reimbursement, frequently without any timely notice, clear justification, or a meaningful opportunity for response. Increasingly, these decisions are driven by automated tools or algorithms that may never review the full clinical context of the patient in front of the provider. This bill is intended to set reasonable guardrails to address that. First, it requires that downcoding be based on a review of clinical documentation, not just on the diagnosis codes or automated tools. AI and algorithms can support decision-making, but they cannot replace clinical judgment, especially when that judgment involves complex, chronic, or high-risk patients. Secondly, the bill protects emergency care by ensuring that services are evaluated based on the patient's presenting symptoms at the time of care, rather than being retrospectively downgraded based on the final diagnosis. Third, it requires timely and transparent notice to providers. If a carrier intends to downcode a claim, the provider must be told why, what criteria is used, and what codes and reimbursement amounts are being changed. This is to be done before the decision is finalized. Fourth, it ensures that the final downcoding decisions are made by a physician or of the same or similar specialty with actual clinical experience in the care that is being reviewed. It is essential that coding decisions reflect real encounters with real patients. Finally, the bill strengthens oversight and accountability by requiring reporting on downcoding practices and by treating downcoding based on non-payment as coverage decisions, subject to appeal and also to regulatory review. This matters because persistent lack of transparency in downcoding erodes trust in our healthcare system. It disproportionately affects providers who care for patients with complex medical needs, and over time, it can discourage physicians and hospitals, particularly those in small and community-based practices, from remaining in network or continuing to serve high-need populations. This bill preserves insurers' ability to manage costs while ensuring that the cost containment does not come at the expense of transparency, fairness, or patient care. At its core, it really is about aligning payment practices with clinical reality and also ensuring that decisions affecting care are made with appropriate expertise, accountability, and respect for the physician-patient relationship. With that, I would ask the committee to consider a favorable report on this bill. Happy to turn over to members of the panel here and to take questions at the end. Thank you.
Hi. How do I, is it on? Am I on? Okay. Hi, Madam Chair and committee members. I'm Dr. Erin Morey. I'm a rheumatologist practicing in Anne Arundel County, and I'm also a member and on the board of MedChi, Maryland Medical Society. I'm testifying on behalf of myself as specialist in MedChi, specialists like me, in support of Senate Bill 797. Rheumatology is a cognitively intensive specialty. We manage complex multi-system autoimmune diseases such as rheumatoid arthritis, lupus, and vasculitis. These require high-level medical decision-making, and when we submit a claim for a high-complexity visit, it reflects the expertise required to manage these high-risk medications and coordinate care for patients with multiple comorbidities. The downcoding that systematically occurred over the summer forced us to actually stop accepting Aetna and Cigna. But for a small practice, this impacts administrative activities. I have limited staff, and they had to spend many hours and weeks appealing these automated decisions, and they had to submit reams of paperwork. This took away from their ability to help me take care of my patients at the office. The financial sustainability, small practices operate on small margins, and systematic downcoding functions as a shadow pay cut that undermines our ability to keep our doors open. And also, it just devalues my judgment on how complicated these patients are. So when we had to stop accepting Aetna and Cigna last year due to this automatic systematic downcoding without chart audit, it directly affected our ability to care for our patients. We appealed every single downcoded claim, and nearly 100% of these claims were restored and ultimately paid out at the originally submitted level of care. That's nearly 100% of them. Why was this happening? Senate Bill 797 brings much needed transparency and fairness to the reimbursement process, and I urge a favorable report on Senate Bill 797. Thank you.
Who would like to go?
I'm going next. Good evening, Madam Chair and members of the committee. Thank you for the opportunity to speak in support of Senate Bill 797. My name is Amy Thomas. I have worked in healthcare for 10 years, owned 2 healthcare companies, one focused on practice analysis and consulting, and the other providing medical billing services. My work centers on revenue cycle management and insurance reimbursement for physician practices across Maryland. I'm here to share real-world data from a local Maryland rheumatology practice experiencing systematic downcoding by commercial insurers. This 3-provider specialty practice submits approximately 80 evaluation and management claims per week. After Aetna expanded its claim on code review program in March of 2025, approximately 70% of the E&M codes were reduced to a lower level of service. The average reduction was about $20 per claim and significantly more when high complexity visits were reduced. That equates to over $50,000 to $60,000 in lost revenue annually. To recover payment from a downcoded encounter, staff must manually review remittances, retrieve medical records, and submit individual appeals consuming approximately 9 hours per week. Without an experienced revenue cycle team closely monitoring payments and adjustments, these reductions can go unnoticed, particularly when billing is outsourced, leading to loss in uncovered revenue. Physicians and advanced practice providers are audited extensively and required to defend every coding decision with detailed documentation and risk recoupment, penalties, fraud allegations, or removal from a payer's network if documentation does not support the claim. Yet insurers can use algorithms and download these same services without prior clinical review or transparency. Practices face audits and penalties, whereas insurers can apply automated reductions without the same level of scrutiny. The imbalance is exactly what Senate Bill 797 addresses. It restores balance, transparency, same specialty, clinical review, formal appeal time, and it prevents non-transparent mass downcoding. For these reasons, I respectfully request favorable report on Senate Bill 797.
Thank you.
Thank you.
Madam Chair, members of the committee, once again, my name is Dana Kaufman. I'm here on Med-Chi. You've already heard from Dr. Maury and Ms. Thomas why this bill is needed, and it has the same theme that you heard earlier with credentialing, that physicians are just trying to be paid for their services that have already been rendered, so that they can also pay for their staff, keep their doors open, and continue caring for patients across Maryland. You're going to hear from insurers that this bill isn't about downcoding. It's really about improper coding by Maryland physicians. But we've heard this narrative before, especially around utilization review, which you just had a discussion about that on the previous bill. But it's important to remember, too, that on prior authorization denials, 70% of those denials are overturned, which in 2024, about $1 million worth of benefits were provided back to patients. So similar to what Dr. Maury said, where near 100% of her claims are paid, but she has to fight to actually get those claims paid. Ironically, the Maryland Insurance Administration has indicated that downcoding already is a violation of the law. However, given the extent that we are seeing it now, we believe that the law needs to be more clearly stated and addressing this issue, especially since Maryland's law is complaint-driven. So under the current law, within 30 days of receiving a claim, the carrier must provide notice if it's going to refuse to reimburse some of the claim. And if it questions the legitimacy, then it is supposed to request additional documentation and give a reason for that. But this is not happening. Instead, as you've heard, the carriers are not issuing the notices. They're not asking for other information. They are just simply not paying at the claim level. And if you don't have the staff to be able to recognize and fight it, you are losing money, and systematic downcoding is benefiting the insurers. So we ask that you please pass this law so we could put some reasonable limitations on what should already be prohibited. Thank you.
Great. Thank you, Madam Chair and members of the committee. I'm Jake Whitaker on behalf of Maryland's hospitals and health systems, here in strong support of Senate Bill 797. And that's really because this bill is about making sure patients don't hesitate to go to the emergency department when they're experiencing things like chest pains or difficulty breathing, simply because they're concerned that they won't get reimbursed for their care. And so this bill will help ensure that patients are covered and that hospitals are fairly reimbursed for that care. So as you may know, federal law already requires our EDs to treat patients based on their presenting symptoms, not their final diagnosis, and regardless of their ability to pay. So take, for example, a patient who arrives to the ED with severe chest pain. Our providers need to act immediately. They need to run complex tests. They need to do evaluations to rule out heart attacks or other serious issues. But take, for example, if those tests show that it's only severe acid reflux, for example, payers will begin to use that benign final diagnosis to reimburse hospitals for a lower level of care. So what we're saying here is that hospitals do all the work, we expend all the resources, and payers use 20/20 hindsight to lower payment for those cases. And to get a sense of how this really works, I do think it's helpful to break down kind of how a medical bill works. So for example, in an emergency claim, it'll include charges for tests, labs, and other work, but the bill will also include charges for the doctor's time, their clinical evaluation, and the work that they actually do. And so what we'll see is that the payers will frequently pay for those complex tests, but then they'll systematically downcode the claims for the doctor's clinical expertise that directly supported and ordered and interpreted those exact same tests. And to be honest, it feels like it's an administrative game just to wear down the hospitals. Insurers know it's expensive for us and time-consuming for providers to contest those claims. And so even when we expend those resources, and as Dana mentioned, we're successful most of the time, the payers still profit. They hold on to the rightful payments for months, they earn investment income off that money, and they still profit even when they pay us and make us whole eventually. And some of the opponents will claim that this will raise premiums. We're not asking the payers to cover anything that their premiums aren't supposed to cover already. So for the aforementioned reasons, we respectfully ask a favorable report. Thank you.
Thank you. And then, who's next? Dion?
Yes.
Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Dion Watts on behalf of LifeBridge Health, here in support of the Senate Bill 797. I am the manager of the claims processing at LifeBridge Health, and I'm here to share what happens operationally after an emergency patient is treated and discharged safely. Across our hospitals, we are experiencing an overwhelming volume of emergency department claims that are automatically downcoded by insurers. These reductions are not the result of a meaningful clinical review. They are generated by software algorithms that reduce reimbursement without a peer physician reviewing the patient's chart, without consideration of the complexity of the presentation, and without context regarding medical decision-making. From an operational standpoint, the impact is significant. Each automated downcode triggers a labor-intensive appeal process. Our billing specialists and clinical staff must step away from their core responsibilities to retrieve records, analyze documentation, prepare detailed appeal letters, and track insurer responses. This is not a quick correction. It is an expensive, resource-draining process. Insurers understand these dynamics. When downcoding occurs at scale, it becomes a game of attrition. Hospitals do not have unlimited administrative staff or financial resources to manually challenge every algorithm-driven reduction. Over time, that imbalance shifts cost onto providers. The real cost is borne by patients. Every dollar an hour diverted to contest arbitrary payment reductions is a dollar in an hour not invested in bedside care, frontline staff, or critical community health services. In an environment where hospitals are already operating under tight margins, this administrative waste directly undermines our ability to focus on patient care. Senate Bill 797 is a necessary step to ensure appropriate review standards and accountability in emergency claim adjudication. On behalf of LifeBridge Health, I respectfully urge a favorable report. Thank you for your time and consideration.
Thank you. Finally, Richard.
Thank you. Good afternoon, Madam Chair and Finance Committee members. My name is Rich Pellegrino. I am the Director of Financial Planning and Reimbursement at Calvert Health Medical Center in Calvert County. Thank you for allowing me the time to testify in support of Senate Bill 797. Consistent with recent data presented by Maryland Hospital Association, Calvert Health Medical Center continues to experience an excessive amount of dollars denied by insurance payers for providing essential clinical care to the patients for which it serves. For the period of July 2021 through June 2025, Calvert Health experienced a total of $16.5 million denied. As Senate Bill 797 is primarily focused on the prevention of downcoding of lower level of care, my testimony will speak to the denied dollars experienced within our emergency department. For the same period, emergency department denied dollars accounted for 44% of the total denied dollars, equating to $7.2 million. This represents 6% of total emergency department charges. Most of the denied dollars reported is due to payers indicating services provided are not medically necessary. 5.7 million of the total denied dollars are from Medicaid managed care organizations. This population represents approximately 24% of the ED charges. Calvert Health serves this population and every patient equally and provides the utmost appropriate medically necessary care to ensure the patient's symptoms are treated successfully 24/7, 365 days a year. Furthermore, the charging and coding of these services are compliant as set forth by the Maryland's HSCRC. Per regulatory guidelines, the level of care charged and coded for each individual patient is based on the resources consumed. Resources include but are not limited to care time, staff intervention, complexity, and severity of illness. Therefore, as regulated by the state of Maryland, reimbursement of these services should be based on the same criteria as charging for these services and not based on a defined level of care algorithm. I thank you for your time, and on behalf of Calvert Health, we support Senate Bill 797.
Thank you. Do I have any questions for this panel? Okay, seeing no questions, that ends this panel. Michael Patty's going to come up favorable. And Michael, if it's okay with you, I'm going to bring Dan Daugherty and Stephen Dargan up. They're favorable with amendments, okay?
Thank you, Madam Chair. Michael Patty here today to support Senate Bill 797 on behalf of the Maryland Community Health System, a network of 7 federally qualified health centers across the state with 55 care delivery sites. And at this point, I just want to say me too.
Thank you, Madam Chair, members of the Finance Committee. My name is Dan Daugherty. I'm here representing the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. We are in full support of this bill. Our amendment, which I have provided to the sponsor and was agreed to, is to add to the bill dental plan organizations as an element or as a carrier that comes under the bill. Many dental plans are other than dental plan organizations. They come under insurers, nonprofit health service plans, et cetera. But dental plan organizations are unique, and they need to be covered because the downcoding issues, the issues of timeliness, et cetera, are the same. So we are requesting that amendment, and we are also requesting an amendment that is commensurate with that, is that in the downcoding of dental claims, that the review be made by a licensed dental dentist as opposed to a physician. Thank you. And with that, we would urge a favorable report with those amendments.
Yeah. Thank you, Madam Chair, committee members. I'm Steve Dargan, representing the Maryland State Dental Association. We are in favor of this with amendments that do have the language, including the dental management, dental plan organizations. We have the same issues with downcoding as physicians, and I give you a brief example. A patient comes in, emergency, long-standing patient, has a broken tooth. We place a crown on there. We submit to the insurance company. The insurance company downgrades it to a large filling, which is going to break. And then the patient is stuck with either a large copay because of that lower fee, or the dentist, in many cases, will make arrangements with the patient to accept a lower fee. So thank you again, and please, we're in support with our amendment, including dental plan organizations. Thank you.
Thank you all for your testimony. You have any questions? No, that ends this panel.
Thank you.
All right, and now we have the unfavorables. Joseph Wynn, Matt Celentano, Allison Taylor, and Kimberly Robinson. I've called those names a few times today.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor on behalf of Kaiser Permanente. And actually, I'm pleased to say you'll hear less acrimony, at least from me, than maybe was anticipated. We are opposed as introduced. I do think there's room to work on this. And I start with some agreement we have with some of the sponsors panel. One is we do agree this is already, we see this as already prohibited by law, and to that extent, carriers certainly should be following the law. And if there's an issue there, maybe that's something we could work on as an enforcement matter with the MIA. I would also agree with what Mr. Whitaker was describing about ED claims and the appropriate standard for reviewing those, the prudent layperson standard that is in the bill. So I do think some of the language in this bill is is overbroad might inadvertently pull in some things that were unintended, but otherwise happy to work with the sponsoring committee on this.
Madam Chair, members of the committee, good afternoon again. Still Joe Nguyen, still Executive Director of the Maryland MCO Association. The MCOs are a diverse group. We're made up of hospital provider and local and national MCOs, and as drafted, this bill would limit our ability to properly review claims for inappropriate, inaccurate billing or a pattern of inaccurate billing. Our provider partners are important and critical aspects of Medicaid. In fact, the majority of the MCOs are provider-led organizations. Nevertheless, we have a real obligation to the state as stewards of state resources to review all claims. These reviews are fundamentally about making sure that payment is accurate, and sometimes these do become payment disputes. And almost certainly the overall process can be done better, both on the payer side and the provider side. We continue to believe that these issues can be handled outside of the legislative framework, and we respectfully request an unfavorable report on the bill. And I'm here to take questions. My written comments are more substantial than my oral comments, obviously. Thank you.
Good evening, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. I want to take a moment to level set a little bit about what the law is today. In Maryland already, all the things that you had described today are in fact prohibited by the insurance article. A carrier in the state of Maryland cannot, as a pattern or practice, in compliance with the law, downcode claims that have been received. And further, under Maryland's law, we are not using algorithms to make our claim determination. In fact, that has always been prohibited under Maryland's law, which requires that all denials have to be made by a human being, by a person in the same specialty as the service being reviewed. That, too, is already law in the state of Maryland. I think what is challenging, and I'm very sympathetic to the experience of the providers, is the fact that 17% of Marylanders are under policies that this bill will affect. And 17% of Marylanders are currently subject to the law as it exists today, to which this bill aligns. Passing the bill will not change the experience for the 83% of Marylanders that these providers may be seeing, who are subject to other states' laws, who do not have the same provisions that Maryland's law does not prohibit pattern and practice downcoding, does not require the same level of review that Maryland does. And so here, my biggest concern with the bill is not where it's duplicative, because it's not going to change anything for us, because we comply with the law. It is going to be some of the more burdensome pieces of the bill that add layers upon layers where we are not deviating from the law, because I think they're trying to capture those who still will not comply. And so I think there's opportunity to talk with the proponents about what is happening today, what may be a potential fix, but I want to make sure that everybody is clear that I think there's a scope issue that is a part of this as well. You all passed a law that requires that Maryland insured members have MIA in the back of their membership card, and I think it would be interesting to see how often the people where this is going on are people who are not in policies that you regulate.
Madam Chair, members of the committee, Matt Celentano here today, again, on behalf of the League of Life and Health Insurers in opposition to Senate Bill 97. I don't want to repeat what you've heard from my colleagues before me, but we just want to reiterate that we believe that the MIA already has broad authority to address what we think is going on in this bill and has the authority to enforce the provisions of the bill already, especially if there is a blanket downcoding. It's already illegal, and if providers see a pattern, they should ask the MIA for enforcement. We can go into the merits of downcoding and why we need to have downcoding as a sort of financial protection against some nefarious actions that we see across the healthcare continuum, but we are willing to continue the conversation, and we're opposed to this bill. Thank you.
Johnny, Senator Mounts.
No. Oh, no. I go. Actually, back home, I go by Senator Johnny. But there is a fiscal note, right? So there is downcoding.
Well, nobody's disputing the fact that there is actually downcoding. Downcoding is a tool that carriers use to review medical records to ensure that the proper amount of billing is taking place. Nobody's disputing that. Carriers don't change the codes, though. They only change the intensity level associated with reimbursement amounts, depending on what they see in the medical record. That, once again, is done by a human. It's not done by an algorithm. And the fact that legislative proposals should really, we think, preserve payment integrity and those tools which ensure transparency and fairness for both sides, the provider and for the carrier. So it's a tool that's it's nothing new, sir.
Yeah, but there's a cost, right?
I think they're
that's
probably
what's driving that note. What is the note?
I don't know what you're referring to, Senator Motz, but I would be happy to. It says that the Medicaid expenditures would likely increase by an indeterminate amount beginning in fiscal year 2027 for additional administrative costs that are created by the bill. Yes.
There's no specific number.
No.
It's the administrative part of it. There's a lot of administrative work that goes into this bill. I think that's where they're seeing the cost. That's the administrative cost.
Yeah, because of the time of day, I'm going to have a lack of a better phrase, but sort of administrative busy work that is included in the bill to sort of layer on top of things that are already standard practice.
Okay. Thank you.
Thank you. Senator Lamb.
Yeah, thank you, Madam Chair. I just wanted to follow up on Senator Moutz's or son, Senator Johnny. I'm looking at this fiscal note a little more closely here. On page 1, it is not just the administrative costs that are being referenced here. It says for additional service reimbursement. So, on one hand, and it seems like there's some discrepancy with, how this panel is playing out. One of the folks have said that there is no downcoding that's occurring, and then I think Mr. Celentano just said,
He meant inappropriate down.
Inappropriate.
Oh, inappropriate. Well,
correct.
Inappropriate's in the eye of the beholder, right? And I think the concern here is that we have practices that are being consistently reduced in intensity, I guess, is your terminology. But really, that's I think an intentional effort to reduce the payment and the reimbursement that's going to these folks. So as a result, in this fiscal note, it's not just the administrative costs that are being referenced here, because on one hand you say that the law doesn't allow for downcoding, and the other hand, if we were to pass this, this fiscal note actually says that costs would go up because downcoding would not occur, therefore costs would go up. So it seems inconsistent here, on one hand, for MIA to say that it's not occurring, for you all to say it's not occurring, and then the department to say, well, if this bill were to pass, then costs would go up.
That may be,
You do want?
Sure, I'll take it. That may be a good question to ask MDH about the fiscal note. I'm sure they're the ones that provided the information about Medicaid. As Ms. Robinson said, there's nothing in here about the impact to the state employee plans. So it's a good mystery, maybe.
Well, I think this is referencing back to the MCOs that are under state Medicaid, and so I think what it's acknowledging is that downcoding is occurring, that there are loopholes in the current statute that allow for downcoding, however you want to define it, inappropriate or appropriate or whatever, that it is actually occurring. And so if we were to pass this, that would put some more guardrails in place on downcoding, then the costs would go up, because you are using downcoding right now to keep costs down.
I don't think that that's actually what's happening, Senator Lamb. I think that when I said that it is inappropriate and illegal for carriers to blanket downcode without the review of the medical records, but with the review of the medical records, when we see an inconsistency, and we see that it is appropriate to downcode for services that are provided, that's a prudent fiscal approach from the perspective of the carriers. Your position might be that we are blanket downcoding and it's only downcoding, but carriers are seeing significant upcoding from the providers as well. And it is part of our job to protect against that as a sort of financial security section. We're seeing examples of coding sort of fraud across the country, especially in Marin. Upcoding, unbundling, phantom billing, misrepresenting diagnosis, AI-assisted fraud. There was just a suit in Tennessee the other day from a carrier against an ER group, Team Health, for $100 million for systematic upcoding that was miscoded ER visits, like sore throats and ear infections, and they were getting coded as high-level complex services. So there is a systematic review that happens with the medical record by a professional coder that is the industry standard to make sure that the proper payments are going to the physicians.
I mean, I don't think we're trying to get at the fact that you can investigate fraud. I think the concern here is that there's just, a system in place that puts the providers at higher risk of systemic level downcoding that's taking place. And all this bill does is just put some guardrails in place. It doesn't say that you can't pursue cases of fraud, or if there's mismanagement that you can't, if there's an intent to defraud payers, we want that to stop also.
But I think the implication of the way the bill is written is that all carriers are systematically downcoding, and that's not the case.
So if that's not the case, what's wrong with putting some basic protections in place here that allow for you to do your job, but also so that we aren't seeing the level of inappropriate downcoding that's taking place?
I think to Ms. Taylor's former comment that there's a reason to continue talking about the bill. There's a lot of additional administrative work that now has to happen, right, under this bill, which I understand if you believe that everyone is systematically downcoding, and if the law is not already addressing this and there's not already a mechanism to address it through our regulatory system. I think there's something to talk about the way the bill specifically is approaching it, right? Because if you are not doing these things, but you now have to invest in all of the additional work that's here, that also adds costs for the consumer because they also pay the administrative costs of having insurance, right? And so what we're saying is, no, we don't care for this bill, but we're happy to continue talking about what might be the right balance between what the wrongdoers are doing that providers are experiencing and also not overburdening the system in such a way that it's just going to exacerbate what happens on the claim side either. So we should continue that conversation.
Happy to continue that conversation. I think, we disagree with, obviously, on the extent to which this occurs and what the current statute does and does not allow to happen. I think it is unfortunate that, that there is a sense that the current law does not allow downcoding to occur, but yet we are seeing instances where, from the perspective of the providers, that there's inappropriate downcoding occurring, and this is really just to put some proper guardrails in place. Thank you, Madam Chair.
I don't see any other questions. Thank you to this panel. Our very last witness of the day is Dr. Dorian. So there you are. Thank you.
Well, thank you, Madam Chair, members of the committee. Thank you, Senator Lamb, for bringing this to everyone's attention. Charles Dorian from the Maryland State Dental Association, the current president, speaking in favor of Senate Bill 797 with the amendments as proposed by Mr. Doherty that include some dental safeguards. I kind of take exception to the claim that healthcare providers tend to be nefarious. Just to give you an example, I asked my front desk staff, what's the most downcoded thing that they face? And they told me it's fillings. Kind of a typical thing we do in the office for restoring dental decay. And the patient's given a choice. There's different materials, gold, composite, or silver amalgam. And most people, 9 out of 10, prefer the tooth-colored composite. They are technique sensitive to place, so they take more time, more materials, more chairside assisting. And so the cost is higher. We submit the claim, and my staff says it always gets downcoded to an amalgam. So I ask you, what is your choice? And it's to the patient's benefit to make the right choice on what material they want to place in the tooth. So for these reasons, as stated before, I ask for a favorable report on SB 797 with the amendments. Thank you.
Thank you. Thanks for hanging in there, Dr. Dorian. Have a good evening.
You too. Thank you.
Thank you. This ends the hearings for today. Senate Bill 837 and all the hearings for the day. Have a good evening.